Hello. Hello, good evening, guys. Hello, please give me a thumbs up if I'm audible and visible. Hello. Chalo. Guys, we'll start. So, okay. We'll start with the anesthesia session. So before starting the session, let me just ask you a few questions regarding anesthesia. Have you learned about this topic of anesthesia before or listening for the first time? Please write in the chat box. Okay, it's already delayed. Okay, some of you have learned clear and loud. Okay, anyways, those who have learned or those who haven't or those who are listening for the first time, no issues. We'll start with this session, guys. Okay, so before starting the session, I'll be just giving you a brief introduction of anesthesia. Anesthesia means what, guys? Before performing any painful procedure, you give anesthesia to the patient so that the patient doesn't feel anything. It produces temporary numbness, not permanent numbness. Okay. Now, the types of anesthesia are, basically remember, if a patient is posted for some small surgery, small part surgery, let it be a dental surgery or any hand surgery, you can give what anesthesia to the patient? You can give local anesthesia. Local anesthesia. Okay. Next is what, guys? Just look over here. If the patient is posted for below umbilicus short duration surgeries. Below umbilicus short duration surgeries means what? Below umbilicus 2 to 3 hours of duration surgery, we can give what anesthesia to the patient? Spinal anesthesia. Example could be appendectomy, torsion of testis, or any diabetic foot or any surgery. Okay. If the surgery is below the level of umbilicus, but the duration is more than 2 to 3 hours, then we can go for epidural anesthesia. Okay? Spinal or epidural. I'm just giving you a brief introduction. Local, spinal, epidural. Okay? Next, if the patient is posted for any surgery above the level of umbilicus, that could be heart surgery, lung surgery, head and neck surgery. In those surgeries, we want the patient fully unconscious. That is general anesthesia. General anesthesia is the only anesthesia technique where the patient is made fully unconscious. Rest all anesthesia technique, patient will be conscious. Okay. Right. So that's regarding the anesthesia techniques. There is one more anesthesia technique which is called as nerve blocks. Nerve blocks means what? Nerve blocks means you are selecting a plexus of nerve. जैसा कि आपके पास है brachial plexus या femoral plexus है, ठीक है, saphenous nerve है. So nerve block means you are selecting a plexus of nerve and you are blocking it, right? So nerve blocks can be done for upper limb surgery or lower limb surgery. Now just look over here and tell me, guys, the thing which I have played, it comes under which anesthesia? Which anesthesia is being performed over here? Come on, be fast. Which anesthesia is being performed over here? You can see mask is being given to the patient. Mask is given to a patient when he is fully unconscious or not breathing. So this is basically general anesthesia. Okay. Inhalational comes under general anesthesia. Inhalational are the drugs. Inhalational agents are given in general anesthesia. Okay. But the technique is general anesthesia. Now, guys, before going to the Malambati classification or anything, just look over here. Before giving any anesthesia to the patient, we basically choose whether the patient is fit for undergoing anesthesia or not. How will you choose the patient is fit for anesthesia or not? By doing a test. What is that test called as, guys? That test is called as PAC. PAC is what, guys? Pre-anesthetic checkup. In pre-anesthetic checkup, you look for 4 important things. 5 or 6 are seen, but 4 important things you look for. One is the airway assessment. Other is basically the investigations. Third is You look for the history and comorbidities, and last is what? You look for fasting status. Okay, so guys, remember in the pre-anesthetic checkup, the most important step is what? The airway assessment. Guys, remember, I have seen many anesthetists making the mistake by not doing the PAC. If you don't do the PAC, you will never come to know your patient is having an easy airway or difficult airway. And during the time of intubation, if you fail, then you will be in the jail. So remember, in the PAC, the most important step is airway assessment. In airway assessment, there are many parameters, but most commonly used parameter is what, guys? Mallampatti classification. Everyone just look over here. When a patient comes to me, I ask the patient to open his mouth. When he's opening his mouth, while he's opening mouth, if I am able to see the tonsillar pillars, uvula, soft palate, hard palate, that means what? He belongs to Mallampatti class 1. He is having a very easy airway. I can easily put the laryngoscope and do the endotracheal intubation. So remember, guys, MP1 is what, guys? Tonsillar pillars, uvula, soft palate and hard palate. Okay? You can remember with this mnemonic. MP1 is push, MP2 is USH, just remove the P. MP3 is remove P and U, it is only SH. MP4 is only H. So guys, remember, MP2, second patient comes to my clinic, he opens his mouth. I am able to see partial, I am able to see partial tonsillar pillars. Okay? Partial tonsillar pillars, but mostly I'll be able to see the uvula, soft palate and hard palate. But guys, remember, whole of the uvula is not seen. Like basically you can see the uvula, but tip of uvula is not seen. Tip is not visible. So that is MP2. Again, this is also an easy airway. You can easily intubate the patient. MP3, the patient who comes to my clinic, opens his mouth. He is a gutka chewer. He is not able to open his mouth easily. Why? Because he's having some mucous fibrosis. When he opens his mouth, I am able to see only the soft palate and hard palate. What does it mean, guys? He is having MP3, which is a difficult airway. Okay? In MP3, you might also see base of uvula. Base of uvula. MP4 means what? Patient comes to my clinic, he opens his mouth and I am able to see only the hard palate. Very difficult airway. And for this airway, you have to prepare yourself or brace yourself for difficult airway algorithm. Okay. There is one more MP which is called as MP0. Guys, remember, MP0 means what? Patient comes to my clinic, opens his mouth. I am able to see all the structures. All structures यानी कि कौन से? Body के नहीं, मुंह के structures. कौन से मुंह के structures? यानी कि MP0 is nothing but MP1 plus tip of epiglottis. MP1 is what? Tonsillar pillars, uvula, soft palate, hard palate plus tip of epiglottis visible. Tip of epiglottis visible. That means the patient is having a very easy airway. So that's regarding what, guys? That's regarding the airway assessment, Mallampatti classification. Now, guys, coming to this question. Okay. Okay. So look over here. A patient is posted for lap cholecystectomy under general anesthesia. Gives you a history of recent MI. Recent MI is recent myocardial infarction 3 months back. Now the patient is stable and he is on dual antiplatelet therapy, that is clopidogrel or aspirin he is taking. What advice we can give? Come on, guys. What advice will you give to this patient? He is posted for an elective surgery, not an emergency. So what you need to give? Can he continue these drugs? Yes or no? Please answer. Can he continue these drugs? Come on, be fast. Some of you are telling yes, some of you are telling no. Okay, just look over here, guys. If you want to answer this, you need to understand what are the drugs which are continued before surgery and what are the drugs which are stopped before surgery. I usually used to remember, guys, सर्जरी यानी कि बेसिकली ऑपरेशन थिएटर जाने से पहले पेशेंट के आप क्लोथ्स निकाल दोगे, यानी कि यू आर पुटिंग ऑफ द क्लोथ्स और यू आर स्टॉपिंग माई क्लोथ्स. पेशेंट्स क्लोथ्स मीन्स माई क्लोथ्स ऑफ द पेशेंट्स आर यूजुअली स्टॉप बिफोर सर्जरी. माई क्लोथ्स मीनिंग व्हाट, गाइस? लुक ओवर हियर. माई क्लोथ्स मीन्स M stands for monoamine oxidase inhibitors. Okay, those are usually stopped 3 to 4 weeks before surgery. Why? Because if you give monoamine oxidase inhibitor and during surgery you are giving pethidine, ये उससे react कर जाएगा और severe sympathetic reaction it will cause. So that's why it is stopped. Next, C stands for clopidogrel. Clopidogrel has to be stopped at least 8 days before surgery. 8 days before surgery. Otherwise, usually bleeding will occur. L stands for lithium. Lithium is what, guys? Mood stabilizer. It has to be stopped 24 to 48 hours prior surgery. Why? Because it can prolong the effect of muscle relaxant. O stands for oral hypoglycemic agents or oral hypoglycemic drugs. T stands for tricyclic antidepressants. Remember, oral hypoglycemic drugs are usually stopped on day of surgery. TCA, tricyclic antidepressants, are usually stopped 3 weeks. Remember TCA, 3 words. So 3 weeks before surgery, you are stopping it. Post-op delirium ho sakta hai, okay? H stands for heparin. Heparin has to be stopped 6 hours prior surgery. And S stands for smoking. Smoking ideally needs to be stopped 2 to 6 weeks prior surgery. But ये होता नहीं है. जितने बार भी पेशेंट को बोलो, पेशेंट बोलेंगे हम वेप मार के आते हैं, कोई बात नहीं होगी, हम हुक्का पीते हैं, हम सिगरेट पीते हैं. पेशेंट यूजुअली does not stop. We tell the patient to stop smoking, he doesn't. So in that case, you have to prepare yourself or brace yourself for a potential bronchospasm during anesthesia. So brace yourself means what? You are preparing yourself with hydrocortisone, and you are also giving some salbutamol inhalation before taking the patient into the operation theatre. Okay. So anyways, sir, kindly inhalational agent of choice वाले सारे क्वेश्चंस भी करवा दीजिए. बहुत कंफ्यूजन होता है. अब सब कराएंगे, कुछ नहीं छोड़ेंगे. ठीक है. Is it clear? So these are the drugs which are usually stopped before surgery. Then what are the drugs which can be continued, guys? All active agents are always approved. All active agents are always approved. Meaning what? Antihypertensives can be continued except of ACE inhibitors and ARBs. ACE inhibitors and ARBs, if you give them, there is a chance of potential rebound hypotension during surgery. So you are stopping ACE inhibitors and ARBs on the day of surgery. ACE, one more A stands for what, guys? Anti-anginal drugs. Anti-anginal drugs can be continued. One more A is what, guys? Anti-lipidemic drugs. Anti-lipidemic drugs can be continued. Atorvastatin, ठीक है, rosuvastatin. One more A stands for anti-epileptic. Last A stands for anti-thyroid medication or euthyroid medication. Any thyroid medications can be continued before surgery without any problem. So these are the things which are stopped and these are the things which are continued before surgery. Okay. Now regarding the fasting. Okay, chalo. Regarding the fasting. Now guys, remember, why is fasting very important? Guys, remember, fasting is very important. Why? Because if you don't tell the patient to be in a fasting state, then the patient will be at risk of aspiration. Now, if the patient is adult and he's taking solid food, any solid food, whether vegetarian or non-vegetarian, how many hours of fasting? 8 hours of fasting. If he's on semi-solid food, any juice with pulp, then how many hours of fasting? 6 hours. If he is on liquid, 2 hours of fasting. Very, very important. Remember, whether it is an adult or child, 2 hours is required when he is on liquid. Liquid can include juices without any pulp. If the child is on mother's milk, remember guys, for child, what we use usually formula that we apply over here is 2, 4, 6. If the child is on water, 2 hours of fasting. Mother's milk, 4 hours. Formula feed, Cerelac, Similac. Then how many hours of fasting? You have to consider that as a full stomach, and 6 hours of fasting you have to take. So fasting plays a very important role, guys. And remember, fasting plays an important role in all anesthesia technique or only one? Okay. Only one or all? Almost all. Remember, even though in general anesthesia you're only making the patient unconscious only in general anesthesia, but fasting plays an important role in all anesthesia techniques. Why? Because if at all, imagine you are posting a patient for surgery under spinal anesthesia. During surgery there is bleeding. Surgeon is telling now give general anesthesia, and you have not checked the fasting status. What will happen? The patient will be at risk of aspiration. So you need to remember the patient should be fasting for all anesthesia techniques, whether it is local also. Okay. Next, after doing the PAC, you give a certificate to the patient that you are fit to undergo anesthesia. That certification is called as ASA certification or ASA classification. Okay, guys. Now, right. Someone is asking me, what about local anesthesia? Just look over here, guys. I have seen many cases. I'll just quote one case to you. Imagine a patient goes to a dentist for root canal therapy. Dentist has given some local anesthetic. He has given local anesthetic in a toxic dose. Now what will happen, guys? You might have heard about this. patient dying due to anesthesia complications. This is happening. Why? Because dentists are giving local anesthetics at a high dose. If you give high dose, what will happen? Arrhythmias will happen, seizures will happen, patient will end up into respiratory or cardiac arrest also, and patient usually is dying. Why? Because the patient is full stomach, he is aspirating when he is not breathing and all. Okay, so whether for any anesthesia technique, you have to go for fasting. Okay, so look over here, guys. ASA classification. ASA is nothing but certification given to a patient that he can undergo anesthesia. Now in ASA there are 6 classes. ASA 1, 2, 3, 4, 5, 6. 6 patients are there. First patient comes to me. I am asking, are you having any comorbidities or systemic illness? Patient is telling, no doctor साहब कोई problem है ही नहीं. If the patient is free from systemic illness, he comes under ASA class 1. Second patient comes to my clinic. Doctor, he is telling, doctor, I am having a systemic illness. I am having diabetes, but I keep my diabetes well under control. I am having hypertension. It is well under control. Patient having systemic illness which is under control comes under ASA class 2. Or you can say patient having moderate systemic illness. Okay. Next, class 3. Class 3 means what, guys? Patient is having systemic illness. यानी कि patient is having diabetes, but it is not under control. It is not under control. So patient basically having a moderate to severe systemic illness, uncontrolled diabetes, alcohol dependence, moderately reduced ejection fraction, or obese patient usually comes under ASA class 3. Okay? Class 4 patient. Class 4 patient comes to my clinic. He is posted for some surgery. I am asking him, are you having any systemic illness? That patient is telling, doctor sahab, recently I had a stroke 3 months back. Now I am having hernia. I came for hernia surgery. But this 3 months back stroke will pose a problem during the surgery. Patient having any life-threatening systemic illness comes under ASA class 4. Example क्या होगा? Recent MI, recent stroke. ठीक है? ASA class 5 means what? Moribund patient without surgery, the chances of survival are very, very less. Ruptured abdominal aortic aneurysm, moribund with multiple comorbidities, bedridden patient. ठीक है? Those patient comes under ASA class 5. ठीक है? ASA class 6 means this patient is brain dead. Brain dead patient में what surgery, sir? Brain dead patient में no surgery. Brain dead patient में you will basically do a surgery called for organ harvesting. Okay, so guys, remember ASA class 1 to 6 in a simple language. How to remember this? Just look over here. ASA class 1 patient will say I am healthy. ASA class 2 patient will say what? I am having mild illness. ASA class 3 patient will say I am having moderate to severe illness. ASA class 4 means what? He will be saying I am having a life-threatening illness. ASA class 5 patient will be telling what? Doctor, I am at the verge of dying. ठीक है? Moribund patient without surgery, no survival. ASA class 6 patient will say I am dead only. So this is basically the ASA classification. Okay. Now guys, starting with this topic called as local anesthetics. Guys, remember what is local anesthetics? First of all, we need to understand before starting this topic, before going to the slide, everyone just look towards me. What are local anesthetics? Local anesthetics क्या है? Local anesthesia अलग है. Local anesthesia यानी कि you are just making a small part numb. That is local anesthesia. Local anesthetics are what? Local anesthetics are the drugs that can be given in all techniques of anesthesia except for general anesthesia. You can give local anesthetics for spinal anesthesia, epidural anesthesia, nerve blocks. ठीक है? Except for what? Except for general, you are not giving local anesthetics. So basically, remember, guys, whenever you are giving local anesthetic to the patient, where are you giving? It can be given at any route. Now, they are, just look over here. Imagine I give local anesthetic on the hand. Okay? Imagine I am giving a local anesthetic over to a patient on the hand, and in the next patient I am giving local anesthetic near the trachea. Okay? Now you guys tell me the chances of the local anesthetic toxicity will be high when it is given at the hand or when it is given near the trachea or near the neck. प्रेगनेंसी भाई, प्रेगनेंसी या ASA2 A3 बोलेंगे ही नहीं. प्रेग्नेंट लेडी, प्रेगनेंसी इज इट अ सिस्टमिक इलनेस? नो ना, प्रेगनेंसी इज नॉट अ सिस्टमिक इलनेस. इफ द पेशेंट इज प्रेग्नेंट एंड शी इज हैविंग सिस्टमिक इलनेस, डायबिटिक है, हाइपरटेंसिव है, तो उसके हिसाब से आप दोगे. ठीक है? प्रेगनेंसी से नहीं. सो द माय क्वेश्चन वाज local anesthetic toxicity will be, chances will be high while you are giving near the trachea. क्यों भाई? उसका reason क्या है? Simple सा reason है, not big logic. Just look over here. Near the trachea you are having major blood vessels. So wherever the blood vessels are high, if you are giving local anesthetic, the chances of its toxicity will be very high. So the chances of local anesthetic toxicity are high when it is given through the IV route, when it is given through the tracheal route. ठीक है? Intercostal, again large amount of blood vessels, and when local anesthetics are given in the brachial plexus, there the chances of its toxicity will be high. So whenever you are giving local anesthetic, in which form it is entering the nerve and in which form it is blocking the sodium channel, one thing you have to be clear: local anesthetics are basically blocking the pain sensation by blocking the sodium channels. Okay, they block the depolarization and block the sodium channels. Now guys, look over here. In which form it is entering the nerve? The non-ionized form enters the nerve. After going inside the nerve, the non-ionized becomes ionized and it blocks what channels? ये जाएगा और sodium channel को block कर जाएगा. So remember which form it is entering the nerve? Non-ionized. And ionized form blocks the sodium channel. The main mechanism of action of local anesthetic is blockage of sodium channel. Okay. Now coming to what? The classification of local anesthetic. They are classified by two categories. One category is called as amino ester और दूसरी category को बोलेंगे हम amino amide. ठीक है? Amino ester बोलेंगे और amino amide. Now guys, look over here. Amino ester में what are the types of local anesthetics? Cocaine, procaine, benzocaine, tetracaine, proparacaine. How will you remember? All the amino esters are having one I. ठीक है? The commonly, remember the local anesthetic which was first used local anesthetic is cocaine. Cocaine तो आजकल यूज ही नहीं कर रहे हैं, आजकल तो cocaine से फूक रहे हैं. ठीक है? Cocaine was used as a local anesthetic and it was used for eye surgery as well as spinal anesthesia. Nowadays it is not. It is the most abused one. Okay? Proparacaine is a topical ocular local anesthetic. But the most important thing is what? If any local anesthetic is having one I, it is amino ester. कैसे याद रखेंगे? Amino ester is having one I. All the drugs of amino esters, all the daughter and sons of amino ester will also have one I. Whereas amino amide, it is having two I's. So all the family of amino amide will have two I's. What are the examples of amino amide? Lignocaine, mepivacaine, bupivacaine, prilocaine and dibucaine. Guys, look over here. Under the amino amide, which is the most commonly used local anesthetic worldwide, always you have to remember it is lignocaine. Okay, which is most commonly used in spinal anesthesia. Very, very important. Bupivacaine. But remember, bupivacaine is the most cardiotoxic local anesthetic also. When bupivacaine is the most cardiotoxic local anesthetic, then why are we using that commonly in spinal anesthesia? Reason being what guys? ब्यूपीवकीन कार्डियोटॉक्सिक है, लेकिन कहां दिए? तो ब्लड वेसल में आप ब्यूपीवकीन दोगे तो कार्डियोटॉक्सिसिटी. स्पाइनल एनेस्थीसिया में आप ड्रग कहां पे दे रहे हो? You are giving the drug in the CSF, so no chances of cardiotoxicity. So remember guys, bupivacaine is the most commonly used local anesthetic in spinal and it is the most cardiotoxic local anesthetic. Okay. Now, you also need to remember longest to shortest acting local anesthetic. In longest to shortest acting, the mnemonic is Delhi to Bombay loves Priyanka Chopra or Prem Chopra, any Chopra. Okay. Pariniti also for a change. D stands for what? Dibucaine. T stands for tetracaine. B stands for bupivacaine. Longest to shortest acting. Okay. L stands for lignocaine. P stands for procaine. And the shortest acting local anesthetic is chlorprocaine. Chlorprocaine. Okay. Now in this, the longest is what? Dibucaine. Most cardiotoxic, you have to remember it is bupivacaine. Procaine is the safest local anesthetic in malignant hyperthermia, and the shortest acting local anesthetic is always chlorprocaine. Chlorprocaine. Okay. Now, chlorprocaine or chloroprocaine. Now guys, look over here. Whenever you are giving local anesthetics, sometimes after giving local anesthetic to the patient complains of itching or rashes. Remember, itching or rashes are nothing but allergic reaction. Which local anesthetic will produce itching or rashes? I told you two classification, amino ester or amino amide. In the amino ester or amino amide, which will produce allergic reaction? Always remember, amino esters will produce allergic reaction. Why? Because amino esters are metabolized to a compound called as PABA. What is PABA, bhai? PABA is nothing but para amino benzoic acid. ठीक है, those amino esters which are metabolized to PABA will cause allergic reaction. Now there have been questions. They are not asking amino esters, they are asking which amino esters will cause allergic reaction. Just concentrate on PABA and concentrate on P and B. You will get the answer. The amino ester starting with the alphabet P, that is nothing but procaine, will cause allergic reaction, and B stands for what, guys? Benzocaine will cause allergic reaction. These are regarding what, guys? Amino esters and amino esters that can cause allergic reaction. Now over here, guys, what is the technique which is being used? Come on, just look at this technique and tell me what is the technique that is being used. भाई आप लोग को समझ में आ रहा है, नहीं आ रहा है? क्लियर है ना? इज इट क्लियर? एम आई गोइंग स्लो, एम आई गोइंग स्पीड? स्पीड अगर बोल रहे हो तो अगेन the lecture will be available on YouTube. You can adjust the speed and you can again watch. But if I am going slow, please tell me. Okay, chalo, ठीक है. So what is this technique, guys, over here? It is called as IVRA. IVRA का मतलब क्या है? Intravenous Regional Anesthesia. Look over here. ठीक है, imagine a patient is posted for surgery, but before surgery you look to this patient, he's having cardiac problem, he's having lungs problem, ठीक है, and he's posted for some Colles fracture or some radial fracture surgery. Now this patient, you cannot give general anesthesia because heart is not in a good state, lungs are not in a good state, ठीक है. So what anesthesia you can give to the patient? Can it be done under local anesthesia, guys? No. Local anesthesia will be only given for what, guys? Surface and all. For fractures, you cannot give local anesthesia. Spinal can be given. Spinal is given for below umbilicus. Never it can be given. Epidural, again below umbilicus, never it can be given. Can we go with nerve blocks? Guys, remember, nerve block means you are selecting a plexus of nerve. But this patient is already suffering with lungs problem. Usually most of the nerve blocks will land up the patient into a complication called as pneumothorax. So you cannot go with nerve blocks. What you can do is you can tie a tourniquet. Just everyone look over here. Tie a tourniquet, place a cannula over here. Okay? After placing the cannula, give local anesthetic. That local anesthetic goes to this part only. The tourniquet which you are tying, it will not allow the local anesthetic to go up. Basically, you are achieving a regional anesthesia through the IV route, is called as IVRA, also called as Bayer's block. What is the most common local anesthetic which can be used in IVRA? It is lignocaine. And what is the pressure of tourniquet when you are tying on the upper limb? It should be 50 plus systolic BP. And when it is in the lower limb, it should be 100 plus systolic BP. In the lower limb, I have just written 100 plus systolic. I know it's not visible to you, but it's 100 plus systolic. What is the drug that can never be given in the IVRA? Always remember, the cardiotoxic drug should never be given. What is the cardiotoxic drug? Bupivacaine is contraindicated in IVRA. Okay, guys, remember, bupivacaine, if you give in a toxic dose and all, then there will be chances of toxicity. That was again treated with some other medicine. We'll come to it later. Now coming to lignocaine. Guys, remember, lignocaine है ना, LIG से याद रखेंगे हम lignocaine के बारे में. Lignocaine starts with LIG. With L, what we need to remember, guys, L से क्या याद रखेंगे? Lignocaine is the most commonly used local anesthetic worldwide. Most commonly used local anesthetic worldwide. I से क्या याद रखेंगे? Lignocaine is the most commonly used local anesthetic in IVRA. ठीक है. G से क्या याद रखेंगे? गर्मी यानी कि hyperthermia. So lignocaine can cause malignant hyperthermia. ठीक है. Rarely, but it can cause malignant hyperthermia. So LIG से 3 MCQs याद रखेंगे lignocaine के. Whenever you are giving this most common local lignocaine, remember that should be given in what dose? When you are giving a plain lignocaine, it should be given in 4.5 mg per kg body weight. When you are giving lignocaine with adrenaline, it should be 7 mg per kg body weight. But if you exceed the dose and give, chances of toxicity. What toxicity will happen with lignocaine, guys? Always remember, जैसा ही आप lignocaine दोगे ना, पेशेंट के weird symptoms चालू हो जाएंगे. पेशेंट बोलेगा, डॉक्टर साहब मुझे यहाँ पे कुछ टिंगलिंग सेंसेशन हो रहा है. उसके बाद में ना पेशेंट है ना बोलेगा नहीं, पेशेंट में देखने को मिलेगा ट्रेमर्स को भी आपने अगर नेग्लेक्ट किया तो पेशेंट को हो जाएंगे सीजर्स. ठीक है. If you neglect seizures, patient will land up into respiratory or cardiac arrest also. So remember, what system gets involved in lignocaine toxicity? It is always the central nervous system, and the first sign of Lignocaine toxicity is perioral numbness. That is very, very important. Okay, and any toxicity by lignocaine or bupivacaine, the treatment of choice for any local anesthetic systemic toxicity is 20% intralipid solution. इसको बोल्ड कर लो, कैसे भी याद रखो इसको, ठीक है, 20% intralipid solution. But if at all you are not used lignocaine, you are given bupivacaine, then what will bupivacaine do? Remember, lignocaine will cause CNS toxicity. Bupivacaine always causes cardiovascular toxicity leading to arrhythmias, right? So if at all patient has arrhythmias due to bupivacaine toxicity, you can give amiodarone. But again, the treatment of choice for bupivacaine or lignocaine toxicity is always intralipid 20% solution. Is it clear, guys? For any local anesthetic systemic toxicity. Now, patient is posted for open appendectomy. Which anesthesia should be given? Come on, open appendectomy. Open यानी कि patient laparoscopic नहीं कर रहे हैं. The surgeon will be opening and he will be removing the appendix. Come on, which anesthesia should be given? Be fast so that we can go to the other topic. Otherwise, we'll be stuck over here only. Very good. थोड़े बोल रहे हैं epidural, थोड़े बोल रहे हैं जनरल, थोड़े बोल रहे हैं स्पाइनल. देखो भाई, जनरल अभी गलत दे दिया आंसर, कोई बात नहीं, अभी याद रख लो, ठीक है. Appendix, where is appendix located? Over here. Is it above umbilicus or below umbilicus? Below umbilicus. Below umbilicus surgery, you can go for spinal or epidural. अभी याद रखेंगे क्या? Appendectomy. Appendectomy, if the slowest surgeon also do open appendectomy, he will do in 2 to 3 hours. Fast surgeon will do in 30 minutes. Any surgery below 2 to 3 hours of duration, you have to go for spinal anesthesia. Guys, I'm not talking about the rare cases where we are opening the abdomen and you will see burst appendix, so it will take 4 hours or 5 hours. That is different. Normal appendectomy, open appendectomy, 2 to 3 hours, you have to go for what anesthesia? Spinal anesthesia. So got it, guys? Spinal anesthesia is given for below umbilicus less than 2 to 3 below umbilicus surgery, which is done in 2 to 3 hours. But spinal जैसे ही आप दोगे, या फिर before giving spinal, prepare yourself or brace yourself for some of the complications. Before getting the complications, prepare in your mind, I will get this complication. What complications? Before giving spinal, this is coming to my mind. This picture of monitor usually comes to my mind. What picture? In this, what do you see? You are seeing a heart rate of 46. You are seeing a BP of 76/30. So basically, you are seeing bradycardia, you are seeing hypotension. So you are preparing yourself for the complications. So what I usually used to do is, before giving spinal anesthesia, I keep some drugs such as phenylephrine, okay, phenylephrine or ephedrine I am keeping. Next, atropine I'll keep. Next, pethidine I'll keep. Next, I'll keep laryngoscope and ET tube. I usually prepare in the emergency drug tray. Okay? Now guys, look over here. Why this should come to your mind is because spinal anesthesia is not about just giving it. It is also about managing the complications. So what are the complications, guys? Intraoperative complications and post-operative complications. Immediately after surgery, immediately after giving spinal, you will see what? Hypotension. Hypotension, why do you see hypotension? Why? Because spinal anesthesia produces sympathetic blockade. Next, bradycardia can occur. For hypotension management, you can give phenylephrine or you can give ephedrine to the patient. Okay? It is the most common intraop complication. Very, very, very important, guys. Most common intraop complication. Next, bradycardia. Next, shivering can occur after spinal. Why? Because as it is producing sympathetic blockade of what? Of the lower extremities. देखो भाई, spinal देने के बाद में होगा क्या? Lower extremities के जो blood vessels है, it will get dilated. So all the blood from the upper extremities get settled at the bottom. Patient will have hypotension, and blood is one of the things that maintains our temperature. So patient will also have shivering. So shivering can be easily managed with the help of pethidine. Bradycardia can be managed with the help of atropine. There is one more complication called as high spinal and total spinal. High spinal meaning what? You wanted your drug till this level of T6, but your drug has gone up to the level of nipples. Yani ki drug has your achieved level of block is higher than the desired level. That is called as high spinal. High spinal patient won't be telling I'm having high spinal. Patient will have two features together, hypo and brady together. That means high spinal have occurred. So these are intra-op complications. Post-op complications meaning what, guys? After surgery is done, you go to the patient and you ask, what is the complication? Patient will tell urinary retention. Doctor, I am having the sensation to urinate, but I'm not able to urinate. Due to that, I'm having severe lower abdominal pain, urinary retention. That's why what we are doing before giving spinal, put a Foley's catheter, drain the bladder. Okay. Second complication post-op that could occur is headache. But again, headache is nowadays not at all seen. Why? Because we are using dura separating needle. If headache occurs, usually headache क्यों होता है spinal के बाद में? Due to the puncture of the dura created by your needle. ठीक है? Headache can be best managed by, remember this headache is called as post-dural puncture headache. It can be best managed by conservative management. What is conservative management? After spinal anesthesia, after 2 to 3 days, patient complains of headache. Tell the patient to have coffee, have NSAIDs or water, drink water. If that is not working, the definitive management is you have to close the puncture of the dura with the help of epidural blood patch. Epidural blood patch. Okay. Next, the cranial nerve that could be damaged in spinal is 6th cranial nerve as it is having a long course. Again, I have just written 6th. ठीक है, ऐसा कुछ ज्यादा नहीं लिखा, 6th cranial nerve लिखा. ठीक है. Now guys, remember, where is the spinal given? Spinal anesthesia is given at what level? Normally we are giving in the intervertebral space. Which intervertebral space? Obviously lumbar intervertebral space. कौन सी lumbar intervertebral space? वो important है. It is basically the L3 to L5 lumbar intervertebral space. आप L3, L4 भी ले सकते हो, L4, L5 भी ले सकते हो. Toughest line से you will identify the space. Now, L1, L2 पे क्यों नहीं दोगे? क्योंकि remember, in adults, the spinal cord is usually ending at the lower border of or it ends between the lower border of L1 and upper border of L2. Upper border of L2. ठीक है, that's why in order to avoid the damage you are giving this. ठीक है, now there are some conditions where spinal should never be given. देखो spinal का most common complication was hypotension. If the patient is already in shock like conditions, ठीक है, don't give spinal anesthesia. Shock यानी कि what patient is having ruptured ectopic pregnancy. Ectopic is below the level of umbilicus. 1 to 2 hours में surgery will be done, but patient is already in shock. Don't give spinal anesthesia. If the patient is having a raised intracranial pressure, don't give spinal anesthesia. If the patient's platelet count is less than 80,000 or INR is more than 1.5, don't give spinal anesthesia. If the patient is having abscess, local site abscess means what? Patient is having any infection near the L3, L4 skin, don't give spinal anesthesia. Abscess at the spinal site, don't give spinal anesthesia. Okay, or if the patient is refusing also, don't give spinal anesthesia. These are the contraindications for spinal anesthesia. Now before going to epidural, guys, remember one more important thing for spinal is what are the layers pierced by your needle as you are. What is the CRT? CRT क्या है भाई? CRT क्या है? Correct answer for what? ठीक है, चलो. What are the layers pierced by your spinal needle? Just look over here. As you are passing the needle, you are piercing the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. Very, very important, guys. Ligamentum flavum. जैसे ही आप ligamentum flavum को pierce करोगे, आपको पता चल जाएगा ligamentum flavum is pierced. Why? Because it is the toughest ligament. ठीक है. Next after that is what? Dura. Then there will be arachnoid and there will be subarachnoid. For that, if someone asks me what are the layers that are pierced in spinal anesthesia, I usually tell some say spinal instigates lethargy during anesthesia session. Some say ये mnemonic है. ठीक है. ऐसे क्या याद रखेंगे? पहला हो गया skin. Next is subcutaneous tissue. Next is supraspinous ligament. Next is interspinous ligament. Next is what भाई? Ligamentum flavum. ये बहुत important ligament है. Ligamentum flavum, on piercing of it, you will come to know that you are pierced. Why? Because it is the toughest ligament. You will feel a snap or sudden loss of resistance. Then the next layer that is pierced is dura. Remember, the first pop that you feel is on piercing of ligamentum flavum. The second pop you will feel is on piercing of dura. Once you puncture the dura, you will be in the arachnoid, and the last layer to be pierced is the arachnoid. Arachnoid is the last layer, क्योंकि after arachnoid तो subarachnoid space होगी जिसमें there will be CSF. So very very important, the order, which layer is the toughest, which is the last layer to be pierced in spinal anesthesia. Okay. Now guys, regarding epidural anesthesia. In epidural anesthesia, again the indication is very clear, below umbilicus, long duration surgery. But if I tell just only for this reason epidural is used, then I will be very wrong. Epidural can be used for many things. One of the indication is below umbilicus, long duration. Apart from that, you can place an epidural at the cervical level, thoracic level, at the lumbar level also. Cervical epidural, when you will place, not for cervical surgeries, you are placing when there is what guys, neck radiculopathies or lymph node dissection, you can go for cervical epidural. Thoracic epidural can be placed. Imagine a patient is there who's having rib fracture. He underwent some rib fracture management. Okay? Now, but he's having severe pain. Why? Because rib fracture means while indrawing of the ribs, while inhaling and exhaling of the gases, he will have pain. So at that time, if you want to reduce the pain, you can give a thoracic epidural. For thoracotomy pain, you can use thoracic epidural. Lumbar epidural is used for below umbilicus, long duration surgeries, as well as for the painless labor. For painless labor, you can use lumbar epidural. Okay. The needle that we use in epidural is very, very important. This needle is called as what needle? 2-Hoy's epidural needle. 18 gauge 2-Hoy's epidural needle. Okay. How will you identify the needle? Needle को और से देखो पता चल जाएगा. 1 centimeter of light and 1 centimeter of dark band will be there on the needle. Okay. Now, this is regarding what? This is regarding the epidural anesthesia. Sir, if the options are given adults L3, L4 or L4, L5, L4, L5 you have to mark if it is there. Okay. But in the practice it is L3 to L5 only guys. Okay. In the practice we are not going for L4, L5 या L3, L4 ऐसा नहीं. L3 to L5 कोई भी space जो आपको easily palpable होगी, but not L1, L2 certainly. Okay. Next. Look over here. We are talking about what? We are talking about the oxygen delivery devices. Now look over here guys. Imagine a patient, you are in the emergency room. You are sitting on your chair. The patient is brought to the emergency. He is having difficulty in breathing. His oxygen saturation is 77%. What you will tell the nurse? First connect what? Connect the pulse oximeter and connect what airway device to the patient so that his saturation improves. First, you will tell the nurse to connect the nasal prawns because nasal prawns will deliver how much liters of oxygen? 1 to 6 liters of oxygen वो deliver करेंगे. If the nasal prawns, the patient is not improving on that, then the second device that we use is what guys? It is the face mask, the normal face mask. If that is also not working guys, then you will tell the nurse to put an NRBM. What is NRBM? Non-rebreathing mask. Non-rebreathing mask. If that is also not working, then you tell the patient to apply Venturi mask. Venturi mask usually works on a principle called as Bernoulli's principle. That is oxygen flowing through a narrow constriction with high velocity. Okay? If still not improving, you tell the sister to connect to high flow nasal cannula. Okay? Now guys, remember, they are not asking you what will you connect and all. This you have to remember. Like this only you have to remember so that you can remember what is the flow rate and what is the FiO2 delivered by it. Remember guys, nasal cannula was the first device that we had applied. How much liters of oxygen it will deliver? 1 to 6 liter. That will in turn deliver how much FiO2? 25 to 45%. Next is face mask. If the patient is not improving with nasal cannula, 6 to 10 liters. Remember, face mask will deliver 6 to 10 liters, which in turn delivers the FiO2 of 35 to 65%. Next, if he's still not improving, NRBM. NRBM will deliver 10 to 15 liters of oxygen per minute. Okay? That in turn delivers an FiO2 of 95%. In the conventional oxygen delivery device, it is the delivery, this NRBM is having the highest FiO2. Highest FiO2 in conventional oxygen delivery device. Okay? Next, Venturi mask. Venturi mask is a fixed machine, fixed oxygen delivery device that will deliver 2 to 15 liters of oxygen, which will deliver in turn fixed 24 to 60%. Okay? But the best and the last one is what? High flow nasal cannula. If nothing works, usually in the COVID times, we were using mostly the NRBM and the high flow nasal cannula, which were delivering 40 to 60 liters of oxygen per minute. That will deliver 100% of FiO2. 100% of FiO2, right? So that was regarding the oxygen delivery devices. Next, AMBU. AMBU is nothing but artificial manual breathing unit. If nothing is there in your hospital and the patient is in a gasping state, not able to breathe, connect the patient to a mask and connect to a bag which is called as artificial manual breathing unit, AMBU bag. There are different type of AMBU bag, but pediatric AMBU bag is usually having a pressure relieving valve that relieves the pressure at 30 to 40 centimeters of water to prevent barotrauma. There is one more valve in the AMBU on the inner side of the AMBU that is called as Rubens valve that prevents rebreathing. Rebreathing of carbon dioxide is being prevented. Okay, that's regarding what, guys? AMBU bag. Now imagine, guys, patient was in casualty. आपने patient को high flow nasal cannula भी लगा दिया, but patient is having much difficulty in breathing. If he is not improving in high flow nasal cannula, then you have to connect the patient to ventilators. In ventilators, there are two types, guys. One is called as non-invasive, other is invasive. Very simple. We'll keep it simple. Non-invasive यानी कि you're not going inside the mouth of the patient. You are keeping the mask outside. That is basically CPAP or BiPAP. But what is the prerequisite required over here? The patient should be empty stomach, and the main prerequisite is patient should be conscious. In unconscious patient, you cannot keep this. Why? Because in unconscious patient, if you keep this mask, he will aspirate. Patient should be empty stomach and patient should be conscious. That is a prerequisite. What are the two modes? CPAP and BiPAP. Remember, CPAP is continuous positive airway pressure, and BiPAP is nothing but two levels of pressures are being given to the patient. Higher inspiratory pressure and a lower expiratory pressure. Usually for severe COPD cases, we are using BiPAP. Whereas for the mild cases, we can use CPAP. Okay, but remember, if the patient is not improving on non-invasive, if CPAP and BiPAP patient condition is not improving, or if the patient GCS is going down, then you can go for an invasive mode of ventilator. In the invasive mode of ventilator, dermis what marking? क्या भाई? Didn't get. ठीक है, फिर से एक बार पोस्ट कर दो. what marking are you asking? Okay, I was telling you about the AMBU bag, 30 to 40 centimeters of water. Okay, so look over here. In the invasive mode of ventilator, you are having some modes: CMV, ACMV, and spontaneous. Just I'll give you a brief introduction, guys. Just look over here. Patient who was not improving on high flow nasal cannula, now he is in a gasping state. He is not at all breathing. I will basically intubate the patient, keep on the ventilator. The nurse will ask, sir, which mode I have to keep? I will tell, please give rest to the patient. Keep the patient on CMV mode. In CMV mode, basically the ventilator is taking the whole responsibility of volume as well as the pressure. So look over here, guys. CMV mode. What is the control variable? Nothing is a control variable. The tidal volume as well as the pressure is controlled by the ventilator itself. Is the trigger breathing allowed? No. Trigger breathing means, are you telling the patient to breathe in between? No. No trigger breathing is allowed. And how is the sedation? In the CMV mode, I tell the sister to give a very heavy sedation. I'll tell that, please do. I don't want the patient to fight with the ventilator. But what will be the side effect? As the patient is for a longer time on this mode, the patient will become very lazy and he becomes dependent on this mode. Due to this, he's not using his accessory muscles for breathing, and patient will develop muscle atrophy. So CMV mode is basically the big boss mode of ventilator that basically controls the volume as well as pressure. In ACMV mode, there are two types. If the patient is improving on CMV, we'll go to the other step down mode, which is called as ACMV. In ACMV, the first mode is volume control. What is the control variable in volume control? You are controlling the tidal volume of the patient. Okay? Pressure control, you are controlling the pressure of the patient. When you are controlling the tidal volume, ventilator will adjust the pressure. When you are controlling the pressure, you are adjusting the pressure. Ventilator will generate the volumes and all. Okay. Trigger breathing, is it allowed in ACMV? Yes. Trigger breathing is allowed in ACMV, both modes. Sedation, you will give moderate sedation. Moderate sedation in this. And what are the side effects of this mode? Due to this mode, as you are allowing the patient to breathe, sometimes they might be good breathing, sometimes they might be bad breathing. That can lead to either hypoventilation or that can lead to hyperventilation. अगर hypoventilation हो तो respiratory acidosis होगा, hyperventilation हो गया तो carbon dioxide wash हो गया, respiratory alkalosis भी हो सकता है. Okay? Okay. ठीक है. So Pressure control mode is basically used for ARDS when the compliance is low. Next, if the patient is improving on ACMV mode, then we can go for spontaneous mode. In the spontaneous mode, they are SIMV mode and pressure support mode. SIMV mode and pressure support. SIMV mode means what? You are basically the ventilator is basically allowing the patient to breathe on his own. Whenever the patient is not able to breathe, then the ventilator is giving some support to the patient. But again, for this modes also, there are many chances the patient might develop hypoventilation. Hypoventilation can occur with spontaneous modes. So once again, guys, remember, CMV control is total on the ventilator. ACMV volume control means I am adjusting the volume, ventilator will adjust the pressure. Pressure control means I am adjusting the pressure, ventilator will adjust the volume and all. Okay. Now, in this ventilatory mode, you can add some PEEP to any mode of the ventilator. PEEP is nothing but you are adding an extra soldier to the ventilator. Basically, remember, PEEP is nothing but like, basically imagine, guys, our lung, okay? It's imagine a patient is having ARDS, okay? And small soldiers of our lungs are alveoli, okay? Imagine our lung has gone in a war with ARDS, but it is losing the war. As our lung is losing the war, what will happen? If we are adjusting PEEP on the ventilator, that PEEP will, remember, who are the soldiers? Alveoli were the soldiers. The PEEP will recruit new alveoli. If new soldiers are recruited, they will fight against the ARDS. Okay, so PEEP is nothing but what? It is basically recruiting new alveoli to the patient. If new alveoli is recruited, then what will happen? Oxygenation will be improved. So PEEP is nothing but positive and expiratory pressure. It improves oxygenation. It prevents atelectasis. It decreases the work of breathing. PEEP is used for ARDS, pulmonary edema. You are using the PEEP. Okay. But what is the side effect of PEEP, guys? The side effect of PEEP, if I use much PEEP, then what will happen? Patient will have hypotension. Hence, and patient will also have increase in the intracranial pressure. Why? Because PEEP will reduce the cerebral venous drainage. So look over here. Due to this reason, PEEP is contraindicated in shock-like conditions, and patient who's having any head injury, you don't give PEEP. Right? So last thing about the ventilators, just look over here. Right. So look over here. Respiratory on the ventilators, what is the respiratory rate normally we keep? It is 12 to 18. What is the tidal volume that we give, guys? 4 to 6 ml per kg body weight. 4 to 6 ml per kg body weight. FiO2 you keep is 21 to 100%. PEEP is 5 to 24. Now, if the patient is having respiratory acidosis, what you will do to the respiratory rate? Increase the respiratory rate. I am giving you a condition. If the patient is having respiratory acidosis, you increase the respiratory rate. Carbon dioxide को let out कर रहे हैं, ठीक है? If the patient is having ARDS, how much will be the tidal volume that you keep? ARDS, already the lungs in a bad state. If you give high tidal volume, the lungs will exhaust. Okay? You have to go for lung protective strategy. So you have to go with low tidal volume ventilation. Okay? FiO2 you are keeping 21 to 100% and PEEP you are keeping 5 to 24. Okay? Next. General anesthesia. Usually in child, the spinal cord is ending at the level of L3. Okay? Chalo. General anesthesia. Come on, guys. General anesthesia का मतलब क्या है? General anesthesia means what? I told you. Above umbilicus surgeries, general anesthesia, यानी कि heart surgery, lung surgery, brain surgery, you can go for general anesthesia. The main aim in general anesthesia is you have to make the patient unconscious, make the muscles relax and reverse the patient. How will you make the patient unconscious? With the help of IV induction agents. Very, very important. But if it is a child and you have to make a child unconscious, चाइल्ड को अनकॉन्शियस करने के लिए आईवी लगाना जरूरी होगा. चाइल्ड को आईवी लगाना ही मुश्किल होता है. ठीक है. इफ यू वांट टू मेक द चाइल्ड अनकॉन्शियस, बेटर यू गिव इनहेलेशनल इंडक्शन. Inhalational induction. Normally inhalational agents are used to maintain the patient in an unconscious state, but for children you can use inhalational induction. Okay. Next, for muscle relaxation you use muscle relaxants, and then there were reversal agents. So as we are telling, the IV induction agents, these are the agents that are used to make the patient behosh or unconscious. In IV induction agent, non-opioid and opioid are there. Non-opioid में कौन से? Sodium thiopentone, propofol, ethomidate and ketamine. Thiopentone, propofol and ethomidate usually works on the GABA receptors, whereas our ketamine works on what receptors? NMDA receptors. Apart from ketamine, xenon and nitrous also works on NMDA receptor. Imagine a patient is having a low ejection fraction. You cannot give non-opioid in low ejection fraction. In low ejection fraction, you have to always go with opioid induction. Why? Because opioid does not have that much effect on heart. Okay. But if the patient's heart is good, he's having any heart disease, then you can go with non-opioid. But if the patient's ejection fraction is too low, 20%, normal ejection fraction is mostly above 50-55%. But if it is 20% or 25%, you go with opioid induction. But if it is low, between 30 to 50%, then you can go with non-opioid. And the most cardio-stable non-opioid that could be given for cardiac patient is what, guys? Ethomidate. Very, very important. Most cardio-stable IV induction agent. Why I'm telling ethomidate is a cardio-stable? Why? Because it maintains the BP and pulse rate. Neither it increases the BP nor decreases the BP. लेकिन अगर ethomidate long term दोगे patient को तो होगा क्या? Long term infusion of ethomidate can lead to adrenal suppression. Okay, then there is one more IV induction agent which is called as methotrexate. Methotrexate is given for electroconvulsive therapy. Okay. Next, coming to what the most important IV induction agent which is called as, come on, it's on the screen. सर येलो यूज़ मत कीजिए, मैं नहीं यूज़ किया हूँ भाई येलो, शायद मेरे ख्याल से पहले से लिखा हुआ था, ठीक है, मैं आई विल बी यूजिंग ब्लैक. नेक्स्ट, चलो स्टार्ट कर लेंगे. So look over here, guys. This agent is called as Propofol. In Propofol, what we need to remember, Propofol should be used as an IV induction agent. It should be, remember, Propofol, once you open the vial, it should be used within 6 hours. Otherwise, bacterial contamination can happen. Why? Because it is made up of egg, lecithin, and soy. Egg, lecithin, glycerol, and soy. As it is made up of egg lecithin, it can be used as an what agent? Emulsifying agent. Emulsifying agent. Okay. It is the most painful IV induction agent. Apart from this, ethomidate and thiopentone are also painful, but the most painful is Propofol. Now, regarding Propofol, guys, always you need to remember Propofol, when it comes to your mind, daycare surgery should come to your mind. Propofol and daycare surgery. Daycare means what? Patient admitted on the same day, discharged on the same day. Yani ke surgery on the same day, discharge on the same day. That is called as daycare surgery. Propofol is used as an IV induction agent of choice for daycare surgery. When you remember this point, you can remember all MCQs related to Propofol, such as what? Imagine a patient is posted for daycare surgery. When he comes to me, he will ask, Surgery, are you giving me full anesthesia or full anesthesia means IV agents, inhalational agents, all you will give? What you will tell? No, as you are posted for daycare surgery, I will only give you IV anesthesia. Any general anesthesia given without inhalational agent is called as TIVA. So you will give TIVA in daycare surgery. Hence, for IV induction agent of choice for TIVA is what? Propofol. Next, he will ask you, Surgery, will you put LMA or endotracheal tube? You will tell LMA. Hence, IV induction agent of choice for LMA insertion is Propofol. Next is what? He'll ask, Sir, is the Propofol that you will be giving me for this surgery, will it be having antiemetic and antipruritic property? You will tell yes, it has antiemetic property, it has antipruritic property. You will also tell with this it is also having what? This Propofol is safely given for malignant hyperthermia. Propofol can be safely given if the patient is having acute intermittent porphyria, and it can be safely given for liver disorder. So basically, all in all, Propofol is IV induction agent of choice for TIVA, LMA, antiemetic property, antipruritic property, malignant hyperthermia, acute intermittent porphyria, and what is this thing? Liver disorder, right? Next, what is the opioid that can be used in daycare surgery? Opioid that can be used in daycare surgery is remifentanil. Okay. Next, guys, sodium thiopentone. Come on. Regarding sodium thiopentone, what we need to remember? Sodium thiopentone is what we are discussing about the IV induction agent. बेहोशी की दवाओं के बारे में पढ़ रहे हैं हम. IV induction agents. ठीक है? Sodium thiopentone is an ultra short acting barbiturate. Why it is an ultra short acting barbiturate? Why? Because it is having a rapid redistribution. The moment you give sodium thiopentone, it will get rapidly redistributed into the adipose tissue. क्या स्पेलिंग लिख रहा हूं मैं, adipose tissue, and it gets deposited in the fat and the muscle. Due to its rapid redistribution, it is called as ultra short acting. It has anti-thyroid properties. It can be prepared in all solutions except the Ringer's lactate. If you prepare it, what will happen? Crystals can easily form. Now guys, whenever you are given sodium thiopentone, always remember what are the effects of this drug on various systems in the body. Always remember guys, whenever you give sodium thiopentone, it is the best friend of CNS, enemy of all other systems. When we are discussing about systems, what systems we are discussing? Central nervous system, respiratory system, cardiovascular system, muscle you are discussing, and analgesia. So remember guys, one line and all MCQs. Sodium thiopentone is best friend of CNS and enemy of others. Now guys, listen. If it is a best friend of CNS, can I give sodium thiopentone in CNS pathologies? Yes or no? Please answer this. Yes, the pH is 10.4. Look over here. Can I give sodium thiopentone for CNS pathologies? It's a best friend. Yes, sir. I can give sodium thiopentone in CNS pathologies. Why? Because it will decrease the intracranial pressure. Best friend means decrease the pressure. So basically, remember, guys, it can be given in head injury and neurosurgery. It can be given in, if the patient is having epilepsy, you can give. Why? Because it's having anti-epileptic property. It can be given for narcoanalysis, truth test. Give some dose of sodium thiopentone, patient goes into subconscious mind, जो उससे पूछो वो सही उगल देगा, ठीक है? So that is narcoanalysis. You can go for sodium thiopentone, but it is contraindicated in all other systems. All other systems, यानी कि basically it is an enemy of other systems. Other system means what? Starting with the respiratory. Respiratory, it is an enemy. If it is a respiratory enemy, can it be given for respiratory disorder or contraindicated? Enemy ये बोलते ही contraindications आएंगे. So it can be contraindicated for respiratory disorders such as bronchial asthma. You don't give sodium thiopentone. It's an enemy of cardiovascular system. So don't give sodium thiopentone if the patient is in shock or ischemic heart disease. Why? Because it will cause what? Hypo and tachycardia. Sodium thiopentone causes hypo and tachycardia. Propofol causes hypo and brady. Propofol causes hypo as well as bradycardia. ठीक है? Sodium thiopentone causes hypo and tachycardia. Is it clear? ठीक है? Next, ketamine. Ketamine मेरा favorite IV induction agent. Why? Because it's a complete anesthetic agent. It is a dash derivative. What derivative? It is a phencyclidine derivative and NMDA receptor blocker. Phencyclidine derivative and NMDA receptor blocker. ये मेरा favorite क्यों है? क्योंकि जब भी आप ketamine patient को दोगे, patient as he is recovering from the effect of ketamine, patient will tell some weird things. That is very hilarious to listen to the patient. Okay? Weird things. Why? Because as the patient is recovering from the effect of ketamine, what will happen is patient will have hallucination, delusion. That is called as dissociative anesthesia effect. Okay. There is one more component of ketamine which is called as S-ketamine. It's a psychoactive drug which usually works as a rapid acting antidepressant. Intranasally we are giving this. Okay. So now look over here, guys. Regarding ketamine is total opposite of thiopentone. If someone asks you what is the effect of ketamine on various systems, always remember what was the effect of thiopentone on various systems. Thiopentone was best friend of CNS, enemy of others. Ketamine is the worst enemy of CNS, best friend of others. Okay? Ketamine is the best friend of other systems and worst enemy of CNS. As it is the best friend of other system, ketamine is an IV induction agent of choice for bronchial asthma. Bronchial asthma, you can give ketamine. Ketamine is an IV induction agent of choice for shock as well as cyanotic heart disease. But again, ketamine is contraindicated in ischemic heart disease. Why? Because it is a cardiodepressant. If you give what will it do? Ketamine increases the BP and pulse rate. Hence, we are not giving in ischemic. In cyanotic heart disease, you can give ketamine. Okay. Next, I told you ketamine is the worst enemy of CNS. Worst enemy of CNS, what will it do, guys? Remember, ketamine increases the intracranial pressure, hence contraindicated in head injury and neurosurgery. Ketamine increases the intraocular pressure, hence contraindicated in glaucoma. Ketamine causes epilepsy, hence contraindicated in epileptic patients. Ketamine causes hallucinations, hence contraindicated in already hallucinating patients such as schizophrenia. Never give ketamine. Okay? If at all hallucination happen by ketamine, then it can be easily managed with the help of midas. Midas is nothing but midazolam. Okay? Chalo. Next is coming to muscle relaxants. Now guys, remember, muscle relaxants are the agents that will cause paralysis of the muscle. Induction agents will cause unconsciousness. Muscle relaxants will cause paralysis. Now in this muscle relaxant, there are two categories, depolarizing and non-depolarizing. Remember, we are discussing depolarizing muscle relaxant. In depolarizing, remember the shortest and the fastest acting depolarizing muscle relaxant is always scoline. The other name for scoline is what? Succinylcholine or succinylcholine. Now it is regarded as the shortest acting muscle relaxant. Why? Because the duration is 3 to 8 minutes, and fastest. Why? Because the onset is 30 to 45 seconds. Where it is the scoline metabolized? With the scoline is metabolized by plasma pseudocholinesterase. When you give scoline to the patient, it is metabolized by plasma pseudocholinesterase. But some of the patient will have pseudocholinesterase deficiency. In some patients, there is deficiency of pseudocholinesterase. What will happen to the succinylcholine effect? It will be prolonged. If the succinyl effect is prolonged, what will happen? Will the patient breathe? No. Patient will be apneic. Such an apnea, usually after giving scoline, patient should recover within 3 to 8 minutes. If the patient does not recover after 20 minutes, then it is called as scoline apnea. And what is the cause? Deficiency of pseudocholinesterase. How will you come to know? How will you diagnose this deficiency of pseudocholinesterase? With the help of डाइब्यूकेन नंबर टेस्ट. चलो ये कौन बोल सकते हैं डाइब्यूकेन कहाँ पढ़े सर? हम कोई बोल सकता है डाइब्यूकेन हम कहीं पढ़े थे आज? सर कोई टेस्ट, अच्छा ग्रांड है वो, मुझे कुछ और लगा. सर कोई ग्रांड टेस्ट दे, लास्ट 17 जून को दिया था. ओके सो मेरे भाई पहले ये बोल दो डाइब्यूकेन आज कहां पढ़े थे? वेरी गुड. अमाइनो अमाइड. कौन सा अमाइनो अमाइड? लॉन्गेस्ट एक्टिंग अमाइनो अमाइड. डाइब्यूकेन इज द लॉन्गेस्ट एंड द मोस्ट टॉक्सिक. We are not using Dibucaine for local anesthesia, local anesthetic purpose. Dibucaine is used for Dibucaine number test. कोई पेशेंट में आप अगर pseudocholinesterase deficiency आप सस्पेक्ट कर रहे हो, there you can go for Dibucaine number test. Okay, so imagine guys, you have given scoline to the patient. Patient is apneic, he's not breathing. What you will do? The management is very simple. You just have to give him positive pressure ventilation. Positive pressure ventilation. Okay, so what is the side effect of scoline? As you are giving scoline to the patient, patient will have fasciculation. Whenever you start giving scoline to the patient, patient will have muscle contraction or fasciculation. Due to this rapid muscle contraction or fasciculation, remember, in first 20 seconds, patient will have fasciculations. After that, patient's muscles will relax. But due to the 20-second fasciculation, in the post-operative period, patient complains of muscle soreness. The most common complication is muscle soreness. The second most common complication is what, guys? Hyperkalemia. Hyperkalemia is increase in the potassium. Usually it increases the potassium by 0.5 to 1 milliequivalents. Due to this reason, scoline is already avoided in patients who are already hyperkalemic. ये scoline का था. अभी पढ़ेंगे हम नॉन डिपोलराइजिंग मसल रिलैक्सेंट. इन नॉन डिपोलराइजिंग देयर आर टू कैटेगरीज, बेंजाइल आइसोक्विनोलोनियम्स एंड स्टेरॉइडल. बेंजाइल आइसोक्विनोलोनियम्स are the muscle relaxants that are ending with the term curium, such as atracurium, cisatracurium, ठीक है, mevacurium, doxacurium, ठीक है. Next came the steroidal curonium, such as pancuronium, roccuronium and vecuronium. So in benzyl isoquinolinoniums, you have to remember these are the muscle relaxants that release histamine and that can cause allergic reaction. In anesthesia, these are the agents that can easily cause allergic reaction. Okay. Now remember, in this muscle relaxants, the first introduced is not given in the list also. That is that is D-tupacurare. D-tupacurare we are not using. Why? Because it is causing severe hypotension or severe ganglion blockade. The second introduced was atracurium. Guys, remember, when atracurium came into the market, it became the best muscle relaxant. Everyone were talking about the good effects of atracurium. Why? Because atracurium was undergoing a magical metabolism. What metabolism? What metabolism and elimination? Hoffman degradation or Hoffman elimination. Due to this reason, atracurium became the best muscle relaxant. But after some time, there were two side effects seen with atracurium. What were the two side effects that were seen with atracurium? There was formation of a compound called as laudonosine. Okay? Laudonosine. Funny name, but we have to remember laudonosine. Laudonosine is what, guys? Whenever you give atracurium for a long-term infusion, laudonosine gets formed, the patient will have seizures due to this form. Okay? Next, atracurium was causing histamine release. Atracurium was causing histamine release. Those two side effects, next muscle relaxant came into the market. What is the next muscle relaxant? Cisatracurium. Cisatracurium is like a sister of atracurium, almost having no side effects. This also undergoes same magical metabolism, Hoffman, but it is with less side effects. Cisatracurium. Next came the shortest acting muscle relaxant, which is called as Mevacurium. Mevacurium is regarded as the shortest acting muscle relaxant. Okay? Next came the longest acting muscle relaxant, which is called as what? Doxycurium. Next came the second longest muscle relaxant. Next came the fastest acting. Fastest acting is what, guys? Rocuronium. Next came the cardio-stable muscle relaxant, that is Vecuronium. Okay? So till now we have discussed the cisatrac. Remember, how will you remember? Mevacurium is the shortest and doxa is the longest. You have to remember, my short dog has long tail. My short dog. Concentrate on MNS. M से क्या होगा? Mevacurium, which is the shortest acting non-depolarizing. Shortest acting non-depolarizing. Remember, guys, if someone asks you which is the shortest acting muscle relaxant, answer should be scoline. But if someone is asking you shortest acting non-depolarizing, answer is Mevacurium. Longest acting is what, guys? Dog has long tail. D stands for Doxycurium, which is the longest acting. So you can remember. Next is, remember, Doxycurium is longest, but it is the most toxic. Hence, we are not using it. Instead of Doxa, we are using Pancuronium. What are the important points of Pancuronium that we need to remember? Pancuronium is the second longest acting. Okay? Pancuronium, always remember, guys, RRR was one movie, no? RRR, Rise, Revolt, Revenge, something. Okay? RRR was Pan India movie. So Pancuronium means RRR. R से क्या याद रखेंगे? रेट. कौन सा रेट याद रखना है भाई हमको? उसका प्राइस नहीं, पल्स रेट एंड BP is increased. Hence, it is a muscle relaxant of choice in shock-like conditions. It increases the BP and pulse rate. Next is what? Recovery. With Pancuronium, as it is having a long duration, there will be delayed recovery in the patient. Okay? Next is what, guys? Renal. यानी कि Pancuronium is having renal excretion. Hence, it is contraindicated and renal failure. That's regarding Pancuronium. Next is Vecuronium. Vecuronium, I told you, it is the most cardio-stable. Vecuronium, always remember, V stands for Vecuronium, V stands for Valentine's Day. दोनों में एक चीज कॉमन है. Vecuronium and Valentine's Day. क्या कॉमन होगा? Valentine's Day में भी दिल शेयर होते हैं. यानी कि Valentine's Day में भी क्या बोल रहा हूँ मैं? Valentine's Day में भी दिल शेयर होते हैं, ठीक है? और Vecuronium भी related to दिल है. So Vecuronium, always remember, V for Valentine's, V for Vecuronium and heart. It is the most cardio stable muscle relaxant. Most cardio stable muscle relaxant. Where it is excreted, guys, it is having biliary excretion. If it is excreted to the biliary tract, can we give Vecuronium if the patient is having obstructive jaundice? Absolutely no, sir. Absolutely no. Okay. नेक्स्ट इज रॉकरोनियम. रॉकरोनियम कैसे याद रखेंगे भाई? रॉकरोनियम इसके नाम से याद रखेंगे. RO मीन्स व्हाट? रैपिड ऑनसेट, और इट इज द फास्टेस्ट एक्टिंग मदर रिलैक्सेंट. इट इज द फास्टेस्ट एक्टिंग muscle relaxant. I used to remember Rocuronium as a painful rock star. क्यों पेनफुल रॉकस्टार? Why? Because it is a muscle relaxant that produces pain during injection. Rockstar, why? Why? Because it is a rapid onset. ठीक है, fast acting muscle relaxant. Fastest and shortest, there is a difference. Fastest means onset is fast. Shortest means duration is small. So basically that's regarding the muscle relaxant. Next, coming to inhalational agent. Guys, remember, inhalational agents are used for what purpose? Inhalational agents are used for maintaining the patient in an unconscious state. Inhalational agents क्यों यूज करते हैं? पेशेंट को बेहोश मेंटेन रखने के लिए. बेहोश करने के लिए आईवी इंडक्शन दोगे, बेहोश मेंटेन करने के लिए inhalational agent. These inhalational agents are usually working on two principles. Remember, in children, inhalational agent you can be used for induction purpose also. So they are working on two principles, MAC and blood gas coefficient. MAC is nothing but minimal alveolar concentration. MAC indicates the potency of inhalational agent. But MAC and potency are always opposite. What does it mean? High MAC is equals to low potent and low MAC is equals to high potent. Low MAC is equals to high potent. ये हमेशा opposite direction में जाएंगे. Low MAC यानी कि high potent. Next, it works on principle of blood gas coefficient. Blood gas coefficient principle works on what? It indicates the patient inhalational agent speed of onset and recovery. Again, blood gas coefficient is also inversely proportional to the speed of onset. Any inhalational agent with high blood gas coefficient will have slow onset, and any inhalational agent that is having a low blood gas coefficient will have fast onset and fast recovery. Okay? So what are the, just 1 second guys, 1 second. So what are the inhalational agents? Just you need to remember, inhalational agent which are low MAC to high MAC. Low MAC to high MAC are what? Examples, HISD याद रखेंगे. If you write this in opposite direction, DSIH, then it will be low blood gas to high blood gas. Low blood gas to high blood gas. ठीक है? Low MAC to high MAC. The lowest MAC is what? Halothane. Next, isoflurane. Next, sevoflurane. Next, desflurane. So halothane is the most potent. Lowest MAC है ना? Most potent. ठीक है? Next, low blood gas to high blood gas. Example, desflurane, sevoflurane, isoflurane, halothane. What does it mean? Desflurane is having a low blood gas coefficient. That means it is a fastest acting inhalational agent. Fastest acting inhalational agent. येलो कुछ नहीं दिख रहा है मेरे भाई. बहुत टाइम चला जाएगा अगर येलो को हाईलाइट करने रहेगा तो. ठीक है, चलो anyways you will be getting the PDF, right? So guys, look over here. Regarding inhalational agents, sevoflurane. Sevoflurane is a very special inhalational agent that is used in children. In children, we use sevoflurane for two reasons. Okay? It can be used for induction as well as maintenance. Induction as well as maintenance. It doesn't mean that sevo is just used for children. We can use sevo for adults also. Sevoflurane is the inhalational agent of choice for bronchial asthma. In children, you can use sevoflurane. Why? Because it's having a sweet odor. In daycare surgery, you can use sevoflurane. Previously, we used to use desflurane, but it is causing laryngospasm and airway irritation. That's why we are not using desflurane. We are using sevoflurane. Next, neurosurgery also we are using sevoflurane. It is avoided in renal patients. It is avoided in patients who are having any renal problems. Why? Because sevoflurane, if you give with low flow anesthesia, it is forming a compound called as compound A or olefin. We'll discuss later. Okay. Next, isoflurane. Isoflurane is the most common inhalational agent used in cardiac surgery, safely given in renal patients. But the side effect of isoflurane is what? It can cause coronary steal phenomena, but it is causing coronary steal phenomena only in animal studies. Coronary steal phenomena. Yani कि coronary steal phenomena means stealing the blood from the good coronary and giving to the bad coronary artery. ठीक है? That is coronary reverse Robin Hood phenomena. Next, halothane. Halothane is very, very important. हाँ भाई देखो methoxyfluorine lowest है, देखो methoxy is lowest but we are not using that मेरे भाई, we are not using that. Methoxyfluorine is having a MAC value of 0.16, halothane has MAC value of 0.75, so methoxy is the lowest but again we are not using that. That's why go with the mnemonic HISD. Okay, तुम्हारे लिए बोल रहा हूँ, मुझे तो कोई इशू नहीं है ये लोग का बार बार. चलो चलो ठीक है. Halothane. Halothane के बारे में what we need to remember? Halothane is a very important inhalational agent. 4 heads of halothane you have to remember if someone is asking about halothane. What are the 4 heads of halothane? First heads of halothane is what? Hyperthermia. What hyperthermia? Halothane is an inhalational agent that can cause malignant hyperthermia. Next heads of halothane is what, guys? Hepatitis. If you are repeatedly giving halothane to any patient for repeated time, for repeated surgeries, then it will cause immune related damage to the liver that can cause hepatitis. Halothane induced hepatitis can occur. Next hedge of halothane is what? Halothane is contraindicated if the patient is having heart disease. Okay? Why? Because halothane, what will it do? It will cause hypo and bradycardia. Apart from that, halothane can release or halothane can basically make the myocardium sensitive towards catecholamine that can cause arrhythmias. Next, halothane has 2 maximum. What 2 maximum? Halothane can produce maximum bronchodilation. If halothane is producing maximum bronchodilation, then why I told you sevoflurane is the inhalational agent of choice for asthma? Halothane should be inhalational agent of choice for asthma, but halothane is causing some increase in the airway resistance. Due to that, halothane is no longer used as the first inhalational agent of choice for asthma. It's the second inhalational agent. Next, it can cause maximum muscle relaxation also. Okay, 4 points of halothane you have to remember with 4 heads of halothane. ठीक है मेरे भाई. Next, monitoring in anesthesia. Now guys, remember before going to monitoring, okay, we'll start monitoring in anesthesia. So guys, remember before going to monitoring in anesthesia, we are now in the general anesthesia. In the general anesthesia, we have given all the things. Now we have to monitor the patient's vitals. How will you monitor the patient's vitals? For monitoring the vitals, you have to monitor the oxygenation. Oxygenation is monitored by pulse oximetry, which is usually working on what law? Beer-Lambert's law. Beer-Lambert's law. Law of absorption and reflection. Next, ventilation. For ventilation, what you need to monitor? You need to monitor the capnograph. Okay. Next, circulation. Circulation can be monitored by BP, ECG, and transesophageal echocardiography. In the BP, you are having IBP and NIBP. IBP is invasive blood pressure monitoring, in which we are using the artery. Which arteries commonly used, guys? Radial artery. But before taking a radial artery, check the patency of the radial artery with the help of Allen's test. Very, very important. The patency of radial artery can be checked with the help of Allen's test. Next, ECG you are monitoring. In ECG, are you monitoring the full 12 leads? No, only 2 leads are important. Lead 2 monitors arrhythmias, whereas lead 5 of the ECG monitors ischemias. Okay. Next, TEE. What is TEE? Transesophageal echocardiography. Again, this is a sophisticated monitor. Whenever you are suspecting any venous air embolism and all, you can go for that monitor. Next, temperature. In temperature, what are you monitoring, guys? Core and peripheral temperature monitoring. ठीक है, peripheral यानी कि आप कहीं भी बगल में लगा दो यहाँ पे temperature, या भी कहीं भी आप skin पे check कर सकते हो peripheral temperature. But core temperature monitoring is very important for general anesthesia cases. What are the sites for core temperature monitoring? Most commonly, we are using what? Esophagus. We are taking a probe directly, keeping it in the mouth of the patient and pushing the probe inside, such as pushing the Ryle's tube. ठीक है? That is, esophagus is the commonly used site, but it is not the accurate one. Sometimes you might get wrong temperature. The most accurate is what? Pulmonary artery, most accurate site for temperature monitoring. But again, pulmonary artery means it's an invasive. Hence, we are not using that. Next, awareness. Sometimes during surgery, patient might be aware. Okay? In that time, you have, how will you monitor the patient is aware or not? With the help of bispectral index. Bispectral index calculate the sum of EEGs. EEG is nothing but electroencephalograph. Okay. Apart from that, neuromuscular monitoring was also done. Now guys, remember, neuromuscular monitoring means in the neuromuscular monitoring, you're having many monitors, train of 4, single twitch, double burst. Just look over here, guys. Everyone look over here. You will understand what is train of 4. In train of 4, you are basically keeping an electrodes over here. Okay? Okay, you are keeping electrodes over here. You are stimulating. Okay? While stimulating, what you will see, whenever you stimulate the patient, you will see a twitch. Stimulate, twitch, stimulate, twitch, stimulate, twitch. So look over here. Imagine I am the patient. Okay, I have not given any muscle relaxant. They have connected train of 4 monitor. Train of 4 will stimulate. I'll get first twitch. 4 twitches are given basically. On first stimulation, first twitch, second, third, fourth. All 4 twitches you are seeing. Okay, that is train of 4 in normal person. Now look over here. If anyone asks me what is the train of 4 ratio in a normal person, what will be your answer? First, you need to understand what he is asking. Train of 4 ratio. What is train of 4 ratio? So train of 4 ratio is nothing but 4th twitch by first twitch response. How was my 4th twitch by first twitch response? Just look over here. First was like this, second was like this, third was like this, fourth was like this. All 4 twitches of equal height, they are increased. So how will be the train of 4 ratio in normal person? In normal person, the T4 by T1 train of 4 ratio will be 1. Normal only. All twitches equal height. If I receive a depolarizing muscle relaxant such as choline, everyone look over here. Someone has given choline to me, and now train of 4 is done. Just look over here. Okay? First twitch like this. Sorry. After giving choline, just look over here. First twitch will appear like this. Second twitch, same. Third twitch, same. Fourth twitch, same. So look over here. After giving choline, what change you have noticed? Before giving choline, the intensity was high. Now after giving choline, the intensity is low, but you are seeing all 4 twitches which are equally reduced. So in depolarizing muscle relaxant, what is the train of 4 ratio, guys? All 4 twitches are of same height. They are decrease and of same height. Just look over here. T1 is like this. T2 is like this. T3 is also like this. T4 is also like this. Previously, normal person, how was the twitches? T1 was like this, like this, like this, and like this. So remember, in depolarizing muscle relaxant also, the train of 4 ratio, which is T4 to T1 ratio, it is always 1. But in case of non-depolarizing muscle relaxant, what will happen to the train of 4 ratio? Just look over here. Non-depolarizing. After someone gave me vecuronium or vecuronium or cisatracurium, just look over here. What will happen? The first twitch appears like this. Second twitch like this. Third twitch like this. Fourth twitch like this. Everyone have seen? Once again, I'll repeat. First twitch like this. Second, third, fourth. So basically what is happening to my twitches over here? First like this. Second like this. Third like this, and fourth is very much reduced. So basically you are seeing a fade phenomena is seen in non-depolarizing muscle relaxant. And what will be the ratio over here? In non-depolarizing, it is always less than 0.4. Very, very important. So what is the most common nerve that is being used in train of 4? Ulnar nerve. Muscle that is being used, adductor pollicis. Adductor pollicis. And what is the ratio in depolarizing? Abhi bola main 1. Okay? In non-depolarizing or adequate block, it is always less than 0.4. For reversing the patient, what should be the ratio? It should be more than 0.9. Those are the ratios required. Okay? So that's regarding what, guys? That's regarding the train of 4 monitoring. Is it clear? That's regarding what? Train of 4 monitoring. Now, before going to the reversing the patient, what are the signs of adequate reversal? How will you come to know that now you can reverse the patient? The best bedside sign is what? You tell the patient to lift his head, a sustained head lift for more than 5 seconds. Sustained head lift of more than 5 seconds. That is a good sign that you can give a reversal to the patient. But overall, the best clinical sign is what? The train of 4 ratio more than 0.9. If it is more than 0.9, then you need to go for the reversal. In the reversal, in the reversal phase of general anesthesia, you need to give reversal agent against the muscle relaxant. So what are the reversal agents, guys? We are having neostigmine, pyridostigmine, L-cysteine, edrophonium. The most commonly used is what? Neostigmine. But guys, remember, whenever you are giving neostigmine to the patient, always you need to remember what? Neostigmine will cause Cholinergic side effect can cause bradycardia. Hence, you are not giving neostigmine alone. You are giving neostigmine either with atropine or either glycopyrrolate to the patient. So that bradycardia can be combated. Okay? But nowadays a new generation drug is there, which is modified gamma cyclodextrin. It is Sugammadex. Sugammadex is a reversal agent that can be given for rocuronium, or if you are using rocuronium or vecuronium, you can give Sugammadex. This have been questioned many times, guys. Okay. Coming to the summary of general anesthesia. Now, guys, in summary of general anesthesia, what we need to remember is, if the patient is suffering from heart disease, what is the IV induction agent, what is the muscle relaxant, and what is the inhalational agent given? If the patient is suffering with asthma, what is the IV induction? Remember in this line, patient ko pehle, first you will give IV induction, then muscle relaxant, then inhalational. This line should be remembered so that you can remember the mnemonic. Heart disease patient, for remembering what are the agents and all given in heart disease, you have to remember with the mnemonic. Heart enjoys very deep inhalation. What does it mean? Heart enjoys. Enjoys. E stands for what? What is the IV induction agent that stands with E? Ethomidate. Okay. Muscle relaxant. V. What is the muscle relaxant of choice for heart disease patient? Vecuronium. It is a cardiostable muscle relaxant. Next, deep inhalational. The best inhalational agent for heart disease is desflurane. But most commonly we are using what? Isoflurane. Reason, sir? Reason why? Because desflurane comes with a costly vaporizer. The vaporizer is very costly. Okay. Most commonly we are using isoflurane. Next, for asthma, what's the mnemonic, guys? Asthmatic kits. You have to remember asthmatic kits always seek help. Okay. So IV induction agent will come first. So K say which IV induction agent? Ketamine you can give for asthma. Muscle relaxant is what? A say any muscle relaxant could be given. Seek help. S and H stands for what? What is the inhalational agent of choice for asthma? Sevoflurane. Second best is what, guys? Halothane. Second best is halothane. Okay. Next, shock. For shock, what we need to remember? Shock kills the patient directly or indirectly. Okay. K stands for what, guys? Ketamine is the IV induction agent of choice in shock. Patient. P stands for pancuronium, that could be given as a muscle relaxant of choice in shock. D stands for desflurane and I stands for isoflurane. Okay. Best is desflurane, most common is isoflurane. Daycare surgery. For daycare surgery, what we need to remember? Daycare surgery, patient may sleep. Okay. P stands for what, guys? Daycare surgery mein P stands for, come on, what is the IV induction agent of choice for daycare surgery which starts with P? Propofol. Muscle relaxant with M, Mevacurium. Inhalational agent of choice for daycare surgery, sevoflurane. Sevoflurane. If not sevoflurane, you can go with desflurane, but sevoflurane is best nowadays. Okay. Neurosurgery. So what you need to remember for neurosurgery? Neurosurgeons treat all safely. Neurosurgeon treat all patients safely. T stands for what? What is the IV induction agent? Thiopentone. A से क्या याद रखेंगे? Any muscle relaxant could be given. Okay. Inhalational agent for neuro is sevoflurane. So you can remember neurosurgeons treat all patients safely insane. So I stands for isoflurane. The next best agent is, second best agent is what, guys? Isoflurane. Best agent is sevoflurane. ठीक है मेरे भाई? ठीक है या नहीं है? है तो है बोलो, नहीं तो नहीं बोलो, लेकिन कुछ तो बोल ही दो. भाई, is everything going to your mind या फिर बाउंसर जा रहा है सर पे से? ऐसा नहीं है ना? होप ऐसा ना हो. ठीक है. Next, malignant hyperthermia. Malignant hyperthermia, guys, remember malignant hyperthermia is a condition where the patient's temperature is abnormally elevated with muscle spasm. In anesthesia, there are many things that triggers malignant hyperthermia. Lignocaine can cause malignant hyperthermia. Choline given to the patient can cause malignant hyperthermia. All inhalational agent can cause malignant hyperthermia. Most commonly, you see malignant hyperthermia incidence with what? Halothane. So guys, remember, malignant hyperthermia is what, guys? It is an autosomal dominant. It is seen in autosomal dominant patient. What is the gene responsible? RYR1 gene responsible. And what will happen, guys? Remember, whenever you give an autosomal dominant patient choline or any of the triggering factors, what will it do? It will go to the abnormal ryanodine receptor and it will stimulate the abnormal ryanodine receptor to release the calcium. And due to the release of the calcium, the patient is having muscle spasm. So what is the channel that usually gets involved over here? It is the calcium channel that usually gets involved in malignant hyperthermia. And this muscle spasm usually starts in what muscle? In the masseter muscle. Thereby the whole body gets involved. How will you diagnose malignant hyperthermia? With the help of a procative test which is called as halothane caffeine bath. Halothane caffeine test or halothane caffeine bath can be done for malignant hyperthermia. And once malignant hyperthermia is diagnosed, what is the drug of choice that we need to remember? It is always IV dantrolene sodium. But guys, remember, there was a question. They gave a question of malignant hyperthermia and they told what should be done first. Yani कि during surgery, patient was having all the features of malignant hyperthermia. What should be done first? ठीक है. In the option, one option was dantrolene, other option was stop the inhalational agents. So basically, remember guys, what is the answer? Dantrolene is the drug of choice. But during surgery, if you are suspecting malignant hyperthermia, always you have to first stop the triggering factors. What was the triggering factor in that surgery? It is the inhalational agent. So you have to stop the inhalational agent. But the drug of choice remains dantrolene sodium. Next is what, guys? Rapid sequence induction. Have you heard about rapid sequence induction? Have you heard about rapid sequence induction? Rapid sequence induction is nothing but what? General anesthesia given to a patient who is full stomach. That is called as rapid sequence induction. Now, which patients are considered as full stomach? Obese patient, pregnant ladies, GERD, hiatus hernia, emergency surgeries. All these patients are full stomach. Even though they might be telling you 6 hours back we had, pregnant lady, if she's telling 6 hours back she had food, always consider she is full stomach. Why? Because her intragastric pressure is high. If you want to give general anesthesia in this patient, you have to go for rapid sequence induction. If you want to prevent the risk of aspiration. What we are doing in rapid sequence induction? We are giving oxygen. In general anesthesia also we give pre-oxygenation with the patient. But remember, in general anesthesia we pre-oxygenate the patient with the bag mask ventilation. In rapid sequence induction we pre-oxygenate with normal mask. Bag mask ventilation is avoided. BMV is avoided. Okay? Now, immediately after giving IV induction agent, you are telling your assistant to apply pressure on the cricoid cartilage. That is called as Sellick's maneuver. Why he is applying pressure on the cricoid cartilage? Why? Because if he is applying the pressure on the cricoid cartilage, with that he is closing the upper end of the esophagus. Patient should not aspirate. So Sellick's maneuver is done. And when are you removing the Sellick's maneuver? Once intubation is done and there is inflation of the cuff. Once you inflate the cuff, then you remove it. Then remove it. Remove the Sellick's maneuver. Remove Sellick's maneuver. Down just I have written, then remove Sellick's maneuver, nothing else. Okay. That's regarding what, guys? Rapid sequence induction. Okay. Next, coming to what, guys? Anesthesia equipments. In that we will discuss IV cannula. Just look over here, guys. IV cannula, there are different gauge sizes of IV cannula, 24, 22. Starting gauge size, the largest bore is 14. The smallest is 26, purple cannula. How they have been asking on colors and they have been asking on the gauge size as well as flow rates. देखो भाई, color के लिए तो एक बहुत easy mnemonic है. Oh great God, please bless your people. जैसे आप mnemonic याद रख रहे हो ना, always remember it is coming from largest to the shortest diameter. O grade got, O stands for orange, G stands for gray, G stands for green, P stands for pink. ठीक है. Next, B stands for blue, Y stands for yellow, and P stands for purple. Just look over here. What is the size I told you? 14, 16, 2 you have to add 18, 20, 22, 24 and 26 cost. What is the flow rate? Every minute, how much of fluid can be given? We'll start from the down. It is very simple, guys. Down is what? Purple cannula. When you are giving purple color cannula, 10 ml per minute of fluid you can give. 10 ml per minute. ठीक है. 24, double of it. 20 ml per minute. ठीक है. 22 means 30 ml per minute. 30 ml per minute. 20 gauze 50 ml per minute. 18 gauze 100 ml per minute. 16 gauze wide bore, more wide bore, so 200 ml per minute. 14 gauze 270 ml per minute. Normally for shock like conditions we are using 14 gauze. ठीक है. For normal surgeries, we are using what cannula, guys? Pink and green. Even though I am saying pink and green, but in my hospital, we are putting blue cannula. Okay? And for pediatric cases, usually 24 gauze. Pediatric cases, we are using 24 gauze. For neonates, we are using 26 gauze, guys. For neonates, 26 gauze IV cannula. Okay? Next. What is this? What is this device, guys? This is called as anesthesia machine. Now, anesthesia machine, there are many parts in the machine. Starting with the first part of the anesthesia machine, which is called as cylinder. Now, in the cylinder, there are two kinds of cylinder. First of all, what is the most common material by the cylinder, which is by which the cylinder is made? It is made by molybdenum. MRI compatible, but these are, remember, molybdenum cylinders are non-MRI compatible. You cannot take the cylinder into the MRI room. They are MRI compatible cylinders which are made up of aluminium and titanium. There are different sizes of cylinder. The smallest size is A, the largest is J, the most commonly used is size E cylinder. Okay? Now the cylinders, by looking at the cylinder, you can tell what gas is there. Why? Because all cylinders are given different color coding. There have been questions on color coding of the cylinders. Okay? Oxygen, air, nitrous, NOx, carbon dioxide. What are the color codings? Just look over here, guys. What is the color coding for oxygen cylinder? Remember, guys, in real life, once you become a good doctor, please keep a bodyguard with you. Nowadays, it is totally needed. Why? Because sometimes whenever you are declaring anything to the patient before listening to you, they will just react in a very harsh way as if you have given the disease to the patient. So you have to keep a bodyguard. When you keep a bodyguard, what will be this dress code, guys? Black color suit with white shoulder cuffling. Okay? That when you are keeping the bodyguard. But when the patient is in the anesthesia, what is a bodyguard for the patient? It is oxygen. So bodyguard color dress code was black body, white shoulder. Oxygen color coding is same. Black body, white shoulders. Black body, white shoulders. Air is totally opposite of oxygen. That is white body, black shoulders. In some countries, air is basically gray color having black and white shoulders. It is gray with black and white shoulders. Okay. Next, nitrous. What's the color coding? Nitrous blue. Nitrous यानी कि नीला याद रखेंगे. नीला is blue. Nitrous नीला, total complete blue cylinder. NOx means what? Blue body, white shoulders. Blue body, white shoulders. NOx is nothing but 50% oxygen, 50% nitrous. Usually given for dental analgesia or for labor analgesia also you can give NOx. C stands for carbon dioxide, which is coming in gray color cylinder. Complete gray color cylinder. Okay. Shoulder colors you have to remember. If you remember the shoulder color, remember cylinders तो होंगे ही machine के साथ में. But if cylinders doesn't work, then hospital is also equipped with central supply of gases that comes with a different color of the pipeline. What is the pipeline color of oxygen? It is the shoulder color of the cylinder. Oxygen का कितना होगा? क्या होगा भाई? White होगा. Air का black. Nitrous, it is blue. Vacuum is used for suction and all. So vacuum pipeline color, remember guys, vacuum starts with what? V. Add a stroke, it looks Y. So vacuum pipeline color will be yellow color. Yellow color. ठीक है. Orange color, देखो भाई, helium हीलियम का होगा ऑरेंज, ठीक है, हीलियम का होगा ब्राउन, ऑरेंज होगा साइक्लोप्रोपेन का, ओके। Next, cylinders are attached to the machine with the help of a steel assembly called as yoke valve assembly. In the yoke valve assembly, there are pins and holes. Pins are present on the machine and holes are present on the cylinder. Just look over here, guys. There, in the yoke valve assembly, there is a system that prevents wrong attachment of the cylinder. I cannot take oxygen cylinder and put into the nitrous port and all. It won't attach. Why? Because different cylinders are given different pin index system. What is the pin index system for air? It is 1,5. Oxygen 2,5, Antonox 3,5, sorry, nitrous 3,5, Antonox 7, carbon dioxide 1,6 and 2,6. अब बोलो कैसे याद रखेंगे सर? A very simple way to remember is air, oxygen and nitrous have one thing in common. The second is 5. यानी कि the second pin usually fits into the fifth port. We just have to remember air का 1,5 है. कैसे याद रखेंगे? Air starts with the alphabet A, which is the first alphabet, so it will be 1,5. Oxygen, always remember O2, O2. So 2, second pin index is always 5 for oxygen. Okay. Nitrous means what? N2O you are writing. 2 molecules of nitrogen and 1 molecule of oxygen means it will be 3,5. Okay. Antonox, it is always 7. This is regarding what, guys? This is regarding the pin index system. Vaporizer. Guys, remember what is vaporizer in the machine? On the machine, you will find a vaporizer that stores liquid inhalational agent in it. What is the common material by which it is made? Vaporizer is made up of copper. Desflurane requires a special vaporizer because it's having a low boiling point. Desflurane has a low boiling point. That's why it is a costly, very costly vaporizer. Color of vaporizer also you have to remember. Halothane, hellfire color is red in color. So halothane, what is the color, guys? Vaporizer color is red. And sevoflurane. Sivo, whenever anyone is telling you Sivo, you have to tell Sivo Semaiya sweet. जैसे कि if anyone asks you halothane, your answer should be 4H. If anyone asks you about pancuronium, answer should be RRR. ठीक है? Sivo Semaiya red. Semaiya means what? Semaiya sweet in color. Sivo Semaiya yellow. You have to remember. So Sivo is stored in what color vaporizer? Yellow color vaporizer. Sivo Semaiya is sweet in color, sweet in taste. That's why Sivo is sweet in odor. Desflurane is basically, you have to remember Desi jersey color is blue. So blue color vaporizer. Isoflurane is purple color, you have to remember. Iso को एक याद रखना पड़ेगा, इसलिए कुछ है नहीं. Isoflurane you have to remember purple color vaporizer. ठीक है? Next, circuits. Circuits are what, guys? Circuits are basically coming out of the machine and you are delivering gases through the breathing circuits. In the breathing circuits, you are having semi-closed breathing circuits and closed breathing circuits. In the semi-closed breathing circuits, they were introduced by a guy called as Mapleson. Hence, they are Mapleson A till Mapleson F. Mapleson A circuit, it is also called as Magel circuit, which is a circuit of choice for what ventilation? Spontaneous ventilation. Very, very important. Here, the fresh gas flow should be equal to the minute volume. Mapleson A circuit. Very, very important. Okay? Next, Mapleson D circuit. Mapleson D circuit is also called as Bain circuit. This is a circuit of choice for controlled ventilation. This is the longest circuit, guys. This is the longest circuit with a length of 1.8 meters. But in order to prevent rebreathing of carbon dioxide, we have given the fresh gas flow how much times the minute volume? 1.5 to 1.6 times the minute volume. Then there is Mapleson E circuit. It is a bagless and a valveless circuit. Okay? What is that circuit called as? It is called as Ayres TPs. That Mapleson E circuit was modified by a guy whose name was Jackson Rees. Two guys with a Jackson Rees. They modified this E circuit, added a bag. Hence, Mapleson F circuit is also called as Jackson Rees modification of type E circuit. And this is regarded as a circuit of choice for controlled as well as spontaneous ventilation in home in pediatric cases. Very, very important, guys. This is regarding the breathing circuit. Which one? Semi-closed. Coming to the closed breathing circuit. In closed breathing circuit, there is no expiratory valve. Okay? All the gases go into a chamber that absorbs carbon dioxide. What is that chamber? What is inside the chamber? Inside the chamber, there could be soda lime or bara lime. Soda lime is what? Soda lime is made up of 80% of calcium hydroxide, which is a major component in soda lime, 16% of water, 3% of sodium hydroxide, which is the main component without which soda lime cannot be formed, and 1 to 2% of silica, which is usually used to make the soda lime granules hard. Okay? But remember, whenever you are using soda lime, 3 inhalational agents you should never use. What 3 inhalational agents? CT scan inhalational agent should not be used. C stands for what? Chloroform kabhi bhi use nahi karenge. Chloroform we are not at all using. Chloroform. Next, trilene we are not using. Next, sevoflurane you are not using. Sevoflurane, if you use with soda lime, I told you, sevo reacts with soda lime to form a compound called as compound A or olefin, which is a nephrotoxic compound. Okay? Then if soda lime is not there, then you can also use bara lime. If you are using bara lime, 3 inhalational agents should be avoided with bara lime. What 3 inhalational agents? Always remember, di-inhalational agents. If you use di-inhalational agents, patient will die. What di-inhalational agents? D stands for desflurane, isoflurane, N-fluorane. Why? Because they can react with bara lime to form a compound called as carbon monoxide. Carbon monoxide. Okay. Next, guys, airway devices. In airway devices, these are the 2 airway devices: Goodell's airway device and nasopharyngeal airway. Remember, if the patient is unconscious, you can use this. Why? Because in conscious patient, if you put Goodell's airway, he will gag it out. Okay. So how will you remember, if the patient is unconscious, patient is having seizures, and he is in unconscious state, in order to prevent the tongue bite, you can put Goodell's airway. But how will you come to know the exact size of Goodell's airway? Keep the airway between the tragus of ear and angle of mouth. If it is fitting, then you can use this airway. But if the patient is conscious, then in conscious patient, you can go for nasopharyngeal airway. If the patient is not able to maintain his airway and you don't know how to intubate, just put a nasopharyngeal airway. But there are some contraindication. Patient should not have skull base fracture. In skull base fracture, if you put an NPA, what will happen? Already the skull base is fractured. Your NPA will also go herniate the. It will basically go through the fracture part, and it will basically damage the brain. So skull base fracture or any bleeding disorder, don't go for nasopharyngeal airway. Okay. As we are discussing the airway, we have to discuss something about the airway anatomy also. What is the narrowest portion of the patient's adult airway? Adult airway, the narrowest portion is the glottic opening. Whereas in case of child, it is the subglottis. It is the subglottis. Okay. Now, if you want to intubate the patient, what you need to do? You need to keep the patient in what position? Sniffing morning air position. Very, very important. For intubation, what is the position required, guys? Sniffing morning air position. But remember, if the patient is obese, you cannot use sniffing morning air posture. You have to use a rammed up position. But in normal position, you have to use sniffing morning air position, where there is flexion at the cervical spine and extension at the atlanto-occipital joint. Very, very important. Okay? After giving the patient this position, then take a laryngoscope. In laryngoscope, you are having 2 blades. What are the 2 blades, guys? Miller's laryngoscope blade is there, or Macintosh laryngoscope blade is there. In adults, we are using Macintosh, whereas in children, we are using Miller's. Why? Because children are having a large epiglottis, which can be easily lifted with a straight blade called as Miller's scope. Once you introduce the laryngoscope, then you have to once you introduce the laryngoscope, you have to lift the tongue. Once you lift the tongue, you will be seeing the vocal cords. Based on the appearance of vocal cords, there is one classification given, that is called as Cormack-Lehane classification or Cormack-Lehane grading. Okay? If whole of the laryngeal aperture is visible, then it is called as what, guys? Cormack-Lehane grade 1. Okay? If only posterior portion of laryngeal wall aperture visible, grade 2. If only epiglottis is visible, grade 3. If epiglottis is also not visible, then it is called as grade 4 Cormack-Lehane. Once you see the Vocal cords. What is your next function? Remember, you have introduced the laryngoscope, you have lifted the tongue. Now, once vocal cords are visible, take the endotracheal tube and directly put the endotracheal tube. Now, which endotracheal tube will we be using? Previously, in Purane olden times, we used to have rubber tubes. We are not using that. The best way to secure the airway is by endotracheal intubation. Okay. And previously, we used to use red rubber tubes, which were high pressure, low volume cuffs. High pressure, low volume cuffs. Okay? But nowadays we are not using. Nowadays we are using what tubes, guys? Very, very important. PVC tubes. Whether in OT, whether in ICU, you are using PVC endotracheal tubes. These are what? These are low pressure, high volume. These are low pressure, high volume cuffs. Why red rubber tubes are not used? Why? Because these were causing pressure necrosis. Once you have intubated the patient, how will you come to know that you are in the trachea? You will auscultate. That is the screening method. But the best confirmatory test that will say that you are in the trachea is by capnograph. Connect the tube to a capnograph monitor and see the capnograph wave. If it is coming, then you are in the trachea. What is the wave that you see, guys? Normally, if you are in the trachea, you will see this wave. Look over here. This is the wave which I am talking about. This wave you will see. Okay? This capnograph wave is divided into 4 phases. 1, 2, 3 and 0. Phase 1 is called as what of capnograph? Inspiratory baseline. Phase 2 is called as expiratory upstroke. Very, very important, guys. Upstroke. Phase 3 of the capnograph is called as alveolar plateau, and phase 0 is called as inspiratory downstroke. Between phase 2 and phase 3 there is an angle called as alpha. Phase 3 and phase 0 there is an angle called as beta. ETCO2 or the capnograph reading that is coming, normal capnograph reading is 35 to 45. That reading usually comes at this angle. So capnograph can be measured, or ETCO2 can be measured. It can be measured at what, guys? It can be measured at beta angle. The importance of beta is that. But remember, ETCO2 is the surest way to confirm the endotracheal intubation. But sometimes after intubating, you might not get this kind of graph. After intubating the patient, you might get a flat capnograph. If you are getting a flat capnograph, what does it mean? Or if you are getting a flat capnograph or flat capnograph value of 0, what does it mean? Either you are not in the trachea, you might be in the esophagus. You will be getting a flat capnograph. Or sometimes you are in the trachea but still you get a flat capnograph. When? After intubating, if the patient develops cardiac arrest, there is no breathing at all. So patient will have what? Flat capnograph. Okay? Apart from that, any other condition where you see a flat capnograph? In complete bronchospasm or total circuit disconnection, you will see a complete bronchospasm, not bronchospasm only. Complete bronchospasm, you will see a flat capnograph of 0. Is this in clear? Right? Next, shark fin capnography. Yani you have intubated the patient. Instead of getting a normal capnograph, you get a capnograph like the fins of the shark. Shark fin capnography is seen in which condition, guys? It is seen when the patient is having bronchospasm. Okay? Complete bronchospasm, there is capnograph value of 0. In shark fin capnography, you will see this capnograph. Next, step ladder capnography. Step ladder means what? Either you will have a capnograph like this, or either you will have a capnograph like this. Step ladder increase. So that is seen in what, guys? In malignant hyperthermia, you will see step ladder capnography. Capnograph above the baseline. Above the baseline means what? Capnograph which is not starting from the baseline. It is above the baseline. It is starting from the middle, like going like this. When it occurs, guys? When the patient is re-inhaling his own carbon dioxide. What is the thing that absorbs the carbon dioxide in a closed circuit? It is the soda lime. When there is exhaustion of the soda lime, or when there is expiratory valve failure, expiratory valve problem, in those conditions you will see what, guys? A capnograph which is arising above the baseline. Sudden fall in capnograph. Capnograph which was normally occurring, suddenly you will see what? There is fall occurring like this. Sudden fall of capnography is seen in a condition called as venous air embolism. The murmur that you see in venous air embolism is what, guys? mill wheel murmur. Mill wheel murmur. Okay. Next, curar notch capnography. Just look over here, guys. Curar notch means what? In between capnograph, while the capnograph is coming normally, slowly you will see a notch developing. What does this notch indicate, guys? Come on. What does this notch indicate? This notch I'm talking about. What does it indicate? Capnograph should be what? Like this. But a notch developing in between means what, guys? Patient is spontaneously breathing. Return of spontaneous breathing indicates this curar notch. So, whenever you see curar notch, what is the next step? That is also important. Next step is what? Curar notch means patient is spontaneously breathing. So, who was maintaining the patient not to breathe spontaneously? Muscle relaxant. So, what you need to do next step? Next step is you have to give the top-up dose of muscle relaxant. Top-up dose of muscle relaxant has to be given. Next, in hyperventilation, when you increase the respiratory rate, what you will see, carbon dioxide gets washed off and you will see a capnograph like this in hyperventilation. When you decrease the ventilation, then what will you see? In hypoventilation, you will see carbon dioxide slowly accumulating and capnograph going like this. So, that is regarding hypo and hyperventilation capnography. Okay. Next, guys. Post intubation chest auscultation was done, but you heard breath sounds only one side. Remember, after intubation, you have to hear the breath sounds on both sides of the chest. Only one side, on the right side of the chest. What does it indicate? Your tube is on the right side. Yani ki your tube has gone into the right endobronchial side. You are too deep inside. So, right endobronchial intubation. Right endobronchial intubation. Okay. Next, what is this tube used for, guys? Come on. What is this tube used for? First of all, what is this tube that is being given on your screen? Come on, very important, guys. It is double lumen tube. Double lumen endotracheal tube. This is used for any surgery that requires one lung ventilation. Why? Because when you insert this tube, it will either go into the right lung and ventilate only the right lung, or left lung and ventilate only the left lung. So it is usually used for what ventilation, guys? One lung ventilation. But after placing the double lumen tube, how will you confirm that it is in the position? You don't tell me capnography. Capnography is usually used for normal tube. Double lumen tube placement can be confirmed by fiber optic bronchoscopy. Fiber optic bronchoscopy. Okay. Next is what, guys? This is a flexometallic tube, or it is also called as armor tube. This is commonly used for what surgeries? Any surgeries that are done in prone position. Patient is posted for some spine surgery or cervical posterior cervical spine surgery, or any surgery, any surgery of the spine. Then if you place a normal endotracheal tube, it will kink or it will bend. But you have to, for patient in prone surgeries, you have to place a flexometallic tube so that if it bends also, it should not kink. Okay, that is flexometallic tube. In prone position surgeries, we are using this tube. Okay, now guys, imagine you are in the operation theater. You are trying to intubate the patient. While trying to intubate the patient, you fail in intubation. What you will do? Bolo. You are trying to intubate the patient. You failed in intubation. What you will do? Bolo, mere bhai. Yes, bolenge. Yes, I failed to intubate. Try again. Okay. और एक बार try किया. Fail हो गया. Then what? Oxygen saturation is falling, guys. Saturation has come down to 70. 2 attempts you guys told me, I have gone for the second attempt, failed. What should I do? Achha, at least 3 attempts. Okay. By looking at the saturation, okay, I will go with your ticket. 3 attempts I have given. Failed in intubation. What should I do? Ideally, if you are in a big hospital, call for help. But if you are in a small setup, what you should do? My saturation has gone down. Your aim should be what? I should ventilate. Leave the intubation. Don't take the intubation on your ego. Intubation is not the only thing that will save life. If you are not able to intubate, ventilate the patient. How will you ventilate the patient? Put the laryngeal mask airway. Your plan A should be give your 3 best attempts of intubation. If that fails, plan B. Plan B is what? Put a supraglottic airway device. I am putting a laryngeal mask airway or supraglottic airway device. Still, I am not able to ventilate. Saturation has gone now to 50. Slowly going down to 40. What should I do? Come on. I have put the laryngeal mask airway. I am still not able to ventilate the patient. What should I do? Be fast, guys. What should I do? I will remove the laryngeal mask airway. I will hold the mask. I'll tell my assistant, you hold the bag and you give the bag. 2% technique of ventilation. That is plan C. Plan C. But if your plan C after trying to ventilate with 2% technique, if that also fails, declare that as CICV. Plan C, if it is failed, declare CICV. What is CICV? I cannot intubate, cannot ventilate scenario. That is a worst nightmare for any anesthetist. In that, you have to activate plan D. That is what? Cut open the trachea, insert the tube, either with the help of needle cricothyrotomy or directly with the help of tracheostomy. Okay. So we were discussing what? Difficult airway guidelines. What were the plan A, guys? You give 3 attempts of intubation. If 3 attempt fails, then your plan B should be what? Ventilate the patient. Ventilate the patient with the help of SGA. SGA is what? Supraglottic airways or LMA. You have to ventilate the patient. Okay? If plan C fails, if plan B fails, if plan B fails, you have to go for plan C. What is plan C? That is 2% technique of ventilation. If that also fails, then you have to go for needle cricothyrotomy or tracheostomy. Needle cricothyrotomy or tracheostomy. Okay, but this is the difficult airway trolley, guys. If you are suspecting any patient is having difficult airway, always keep all things ready. 2 laryngoscope sets, 2 types of endotracheal tubes, many LMAs ready, many types of airways ready. Next, always keep a video laryngoscope ready. Bougie, this structure, bougie. This is a very life-saving structure, guys. While intubation, if you see a tip of vocal cord also, you can easily just put this bougie. Or this is called a stylet. Okay, these are difficult airway things. Okay, this is the tracheostomy tube, guys. There have been one question asked, like, what is the function of the tracheostomy tube cuff? Okay, so remember, tracheostomy tube cuff function is what? It prevents aspiration. Same like any endotracheal tube, it prevents aspiration and also helps in preventing dislodgement of the tube. Preventing dislodgement of the tube. Okay. Okay. Now, as we were discussing about LMAs, guys, remember our plan B was to introduce LMA. LMA are of 2 types, first generation or second generation. First generation, when will we call? If only one opening is there, first generation. Okay. If one more opening you add, second generation. So LMA classic is there, flexometallic is there, Ambu Aura 40 is there, Cobra LMA. These are first generation LMA. Second generation means what, guys? 2 openings are there. One more extra opening is given through which you can introduce the Ryle's tube. It's the esophageal opening. Okay. Example are LMA Proseam, LMA Proseal, LMA Supreme, LMA Igel, Slipa is there, and Ambu Gain LMA. All these LMAs are having 2 openings. 2 openings, second generation. 1 opening, classical LMA. Okay. Now, guys, next we'll start with the steps of CPCR or steps of BLS. Now, guys, remember in basic life support and all, what are the steps that we normally follow? Sir, if there is tracheal deviation, what we'll do? Tracheal deviation भी है तो आपको कॉर्ड्स तो दिख जाएंगे ना भाई. Tracheal deviation भी तो आपको तो कॉर्ड्स में डालना है. You just have to follow the chords. You have to just like introduce the laryngoscope. Introduce करो, chords तो वही वैसे ही दिखेंगे ना. Okay, चलो. So steps of BLS are what, guys? Remember in basic life support, SCCS is what we follow. S is what? Whenever any patient collapses, the first step is what? Scene safety. Look for any hazardous material near the patient. Next is what? Check for the response. You get tap on the patient and check for the response. If there is no response, you call for help. Why do you call for help? Why? Because the one who you call for help, he'll get an ambulance or an AED. Next is what? You check for the pulse and breathing. SCCS. The third C is what? Check for the pulse and breathing. Now, which pulse are you looking for? If he is an adult, you look for what pulse, guys? Carotid pulse. Adults ke liye. And infants ke liye, what pulse you are looking? Brachial pulse. If there is no pulse, no breathing, start your CPR. And how are you starting your CPR? Are you starting with ABC protocol or CAB protocol? You start your CPR with CAB protocol. CAB is what, guys? You start with compression, then airway, then breathing. Compression or circulation, then airway, and then breathing. Now, guys, how many compression you have to give in a minute? Very, very important. 100 to 120 per minute. Depth of compression 2 to 2.4 inches or 5 to 6 centimeters in adults, whereas if it is an infant, then 1.5 inches or 4 centimeters. If the child is more than 1 year, then 2 inches or 5 centimeters or 1/3 of the anterior posterior diameter of the patient's chest. That should be the depth of compression. Okay. Next, ratio of compression 30:2. 30:2 means it doesn't mean in 1 minute 30:2. In 1 minute you have to give 4 sets of 30:2, and in between the compression allow a full chest recoil. Okay. Now, there have been questions on what is the compression to ventilation ratio in adults and in pediatrics. If there is a single rescuer, yani ki I am the only one who is rescuing the adult, whether it is an adult or pediatric, 30:2 the ratio that I will follow. Okay? But if there are more than one rescuer, I am there, my friend is there, both are giving, one is giving compression, other is giving rescue breaths, then in adults, same we are following 30:2. But if in pediatric there is more than one rescuer, then this ratio changes to 15:2. Why? Because pediatric are having higher respiratory rate. Okay. Next, in between giving compressions, if your friend has intubated or put a laryngeal mask airway, then you don't have to stop after 30 compression to give 2 rescue breaths. No, you have to give continuous compressions, but you have to give 1 rescue breath every 6 seconds if you have put an advanced airway in case of adults. Okay? So in 1 minute, how many rescue breaths? 10 rescue breaths. Whereas in pediatrics, what you need to do? Every 2 to 3 seconds you are giving rescue breaths. Yani ki in 1 minute 20 to 30 rescue breaths you are giving. Whereas compression to ventilation ratio in case of newborns, it is what, guys? 3 compression to 1 ventilation. 3:1. That is the ratio that we follow over here. Okay. Now, next. When is this position used? Come on, guys. What is this position? This is called as what position? Rescue position. Rescue position is, or a lateral position is used when the patient collapses and he is having pulse, he is having breathing, but he is not responding. You keep the patient in this position so that he does not aspirate the gastric contents. Why? Because he is unconscious. Unconscious patient can easily aspirate. So rescue position can be used when the patient is having pulse, breathing, but no response. Okay. Now, guys, during CPR, the drug of choice that we give to the patient is what, guys? Adrenaline, the drug of choice. And what is the dilution of adrenaline that we give normally to any patient in cardiac arrest? The dilution of adrenaline should be what, guys? It is 1 in 10,000. Okay. In local anesthetic, it is 1 in 2 lakh. For anaphylaxis, it is 1 in 1,000. How will you give adrenaline? Adrenaline is a drug of choice by IV route. But if IV is not possible, intraosseous route. If intraosseous is also not possible, endotracheal route. If your friend has put the endotracheal tube, take the adrenaline ampule and pour it into the endotracheal tube. It will get easily absorbed. But you require 2.5 times the normal adrenaline dose. Okay. And what is remember, why do you call for help? Why? Because the person who goes for help, he comes with a defibrillator. In defibrillator, in the hospital, we are having this defibrillator, which is called as manual defibrillator. Whereas in the shopping mall, cinema hall, we are having AED, automated external defibrillator. In manual defibrillator, there are two modes. Remember, always in cardiac arrest, we are giving asynchronized defibrillator, asynchronous mode. Whereas for SVTs and other modes, other things, we are using synchronized cardio version. So remember, they are monophasic asynchronous, biphasic. If you are using monophasic, what should be the joules, guys? 360 joules. Monophasic means single 360 joules. Biphasic means what? You can start with 120 joules and you can go to 200 joules. Okay. Now, if the patient, remember guys, you are not giving shock to all patients. You are giving shock if the patient is having shockable rhythm. What two shockable rhythms? If the patient is having ventricular tachycardia, or if the patient is having scribbling time of rhythm on ECG, which is called as what, guys? Ventricular fibrillation. But what if the patient is totally flatline, asystole? Now don't tell, sir, I will declare. No. Sometimes the patient, immediately after cardiac arrest, there might be asystole. It doesn't mean you need to declare. What you need to do? If the patient is asystole, you need to continue CPR. You need to continue CPR. And you need to give adrenaline 1 mg as soon as possible. And it has to be repeated every 3 to 5 minutes. Okay? And then you have to rule out the 5 reversible causes of cardiac arrest. What are the 5 reversible causes of cardiac arrest, guys? Okay? 5 H's and 5 T's. What are the 5 H's and 5 T's? Hypovolemia, hypoxia, hypothermia, hydrogen ion acidosis, hypo and hyperkalemia. These are 5 H's. 5 T's are what, guys? 2 T's related to the heart. What are the 2 T's related to the heart? Coronary, okay, cardiac tamponade, coronary thrombosis. Cardiac tamponade and coronary thrombosis. 2 T's related to the lung are pulmonary thrombosis and tension pneumothorax. And last is what, guys? Toxins. Patient might be under the influence of toxins or drugs. That could be a cause of cardiac arrest. Now, guys, remember, previously there was, these are regarded as a chain of survival. Previously there were 5. Now there is the 6th chain of survival which has added, which is called as recovery. If all these are promptly performed, then the chances of survival would be easily increased. But the 6th thing that is added is what, guys? In the chain of survival, it is the recovery. Once the patient has achieved ROSC, you know what is ROSC? Return of spontaneous circulation. What you need to do? You just have to maintain the airway of the patient, yani maintain the saturation of the patient, which is, your aim should be, the saturation should be 92 to 98. If saturation is 100, no one will ask you, no one will like grab your collar and say why it is 100. Minimum should be 92 to 98%. PCO2 should be 35 to 45 mm of Hg. MAP should be how much? Minimal mean arterial pressure should be more than 90. Sorry. MAP should be more than 65. And systolic BP should be more than 90. That should be aim. And after that, get a 12 lead ECG. If there is a problem in 12 lead ECG, send the patient to a cath lab. If there is no problem, assess the patient response. If the patient is not responding, then you have to, or if the patient is responding, shift the patient to ICU. If he is not responding, you have to shift the patient for CT scan and do after CT scan, target temperature monitoring has to be done. Very, very important. The temperature that you maintain over here is 32 to 36 degrees Celsius. Very, very important. Okay. Next, we'll discuss something about the tachycardia algorithm. Remember, guys, tachycardia, when a patient is having a pulse rate very high, okay, very high pulse rate, imagine 150, more than 150, and how will you manage that? Remember, if the patient is having tachycardia, first you have to know whether it is stable tachycardia or unstable tachycardia. What are the signs of stable or unstable? Stable tachycardia means patient won't have the signs of instability. What are the signs of unstable tachycardia? Hasia. Hasia means what, guys? Patient having hypotension, is altered sensorium, S is signs of shock, eyes, ischemic chest discomfort is acute heart failure. If the patient is having unstable tachycardia, the management is what? Treatment of choice for unstable tachycardia is synchronized cardioversion. Very, very important. Synchronized cardioversion. But if the patient is having a stable tachycardia, then you can go for VABC. V stands for vagal maneuver. A stands for adenosine. That is the drug of choice. 6 mg you give. If not improving, 12 mg. Next, beta blockers you can give. And last is what, guys? Calcium channel blocker can also be given. But remember, unstable tachycardia, treatment of choice is synchronized cardioversion. In unstable, they won't be giving in the question. Patient comes with a feature of unstable tachycardia. No. They will give, patient is having a BP of 70/40, a pulse rate of 170 over pulse rate is more than 170. What is the treatment of choice? He's having a feature of unstable tachycardia. The treatment of choice is always synchronized cardioversion. Is this thing clear, mere bhai? Yes or no? Right? So guys, these were the important things. Is it clear? Is it clear? Okay, these were the important things in anesthesia. Right? Hope you have a wonderful exam. I know even though anesthesia is 5 marks, but my responsibility is you should get all 5 marks from what I have taught. Okay? Please go through the PDF. Immediately I will send. You don't have to ask also. Immediately I will send to the team. Okay? Now it's up to them how. I'll try from my side. I'll try to push that they upload the PDF as soon as possible, because if they are wasting time, if the PDF is not reaching you on time, then it will be problem for you, right? Okay. So okay, hope you like the session, guys. If you're having any doubts and all, sometimes I'm not responding immediately, but I'll respond. You can just connect to me on Instagram. भाई PEEP अलग है, synchronized cardio version अलग है. PEEP is maintained on the ventilator. As a synchronization of PEEP you're asking. Okay, so synchronization of PEEP is maintained by which valve? Thank you, sir, for how many questions you can expect. Like it is totally changing, guys. Like sometimes they are asking 4 questions, sometimes they are asking 2 questions, sometimes you can expect 3 to 5 questions. ओके ठीक है. बेसिकली पीप का कैसा फंडा होता है मैं बताता हूँ आपको. इफ द पेशेंट, अगर आपको लग रहा है कि पेशेंट का ऑक्सीजनेशन कम हो रहा है तो आप पीप को थोड़ा सा बढ़ा देंगे. ठीक है. अपार्ट फ्रॉम दैट उसके अलावा भी है ना, लाइक यू विल लुक इन द एबीजी, एंड अपार्ट फ्रॉम एबीजी पीप का है ना, आप पीप को ऐसा भी कर सकते हैं कि मान लीजिए आप पेशेंट को पीप पर लगा रहे हो. ठीक है. लेकिन आप है ना पीप को, लाइक नॉर्मली फॉर एनी पेशेंट व्हाट वी डू इज लाइक वी कीप अ पीप ऑफ 5 to 7 और 5 to 8. वी डोंट इंक्रीज इट. अगर आप थोड़ा सा, अगर आपको लग रहा है कि पेशेंट का बीपी कुछ कम होता जा रहा है या पेशेंट को इंट्राक्रैनियल प्रेशर के फीचर्स बढ़ रहे हैं, तो आप उसको लो कर दोगे या नहीं यूज़ करोगे. According to the patient need. ठीक है. PEEP is not a mandatory thing, but again, if the patient is on mechanical ventilator and oxygenation is going down, then you have to, and it should be a must thing added. चलो भाई, any other questions? Thank you. Hope you had a wonderful session. Okay. Drop in the comments of YouTube also, guys, how you like the session and what you need an improvement. Okay. Okay, guys. ठीक है, चलिए मिलते हैं, राइट। मेपल का इनपुट यानी कि यू आर टॉकिंग अबाउट मेपल्सन का इनर ट्यूब एंड आउटर ट्यूब, आर यू आस्किंग? या मेपल्सन का आप वो बोल रहे हो कि फ्रेश गैस फ्लो? देखो, फ्रेश गैस फ्लो अगर आपको याद है तो वाई डू यू गिव फ्रेश गैस फ्लो फॉर मेपल्सन सर्किट इज टू अवॉइड रीब्रीदिंग, ठीक है। बट अगेन, अगर आपको ये याद रखने में मुश्किल हो रही है कि फ्रेश गैस फ्लो कितना किस में दे रहे हैं बोले, तो वो छोड़ दो, उतना ज़्यादा वो नहीं है, पीजी के लेवल के लिए इंपॉर्टेंट है, बट नाउअडेज पूछ सकते हैं। इतना ही याद रखो कि मेपल्सन ए में फ्रेश गैस फ्लो आप रखोगे सेम टू द मिनट वॉल्यूम इज नथिंग बट रेस्पिरेटरी रेट इनटू टाइडल वॉल्यूम। एंट्री एग्जिट, अच्छा मेपल्सन का डायग्राम बोल रहे हो? हाँ, मेपल्सन के डायग्राम आप एक बार देख लो। मेपल्सन में है ना एक और चीज़ जो इंपॉर्टेंट होती है वो होती है कि उसमें है ना एक इनर होता है, इनर ट्यूब होता है, एक आउटर ट्यूब होता है, ठीक है। ये यूजुअली है ना मेपल्सन सर्किट आने के बाद में इसको इंट्रोड्यूस किया गया था। क्यों बोले तो पेशेंट को रीब्रीदिंग हो रही थी, तो रीब्रीदिंग को प्रिवेंट करने के लिए एक तो फ्रेश गैस फ्लो को चेंज किया गया, दूसरी चीज़ एक इनर ट्यूब डाला उसने और एक आउटर ट्यूब डाला मेपल्सन सर्किट में। मेपल्सन ए में क्या था बोले तो inner tube was responsible for what gases and outer tube was responsible for what gases, वो आपको याद रखना है। inner tube was responsible for expiratory gases, outer tube was responsible for inspiratory gases, ठीक है। अगर वो पूछ रहे हो तो वो है मेपल्सन का डायग्राम, एक बार देख लो, ठीक है। बट मेपल्सन में जो इंपॉर्टेंट है स्टफ है वो पूछते हैं, मैगल सर्किट कौन सा है, सर्किट ऑफ चॉइस फॉर स्पॉन्टेनियस कौन सा है, ब्रेन सर्किट कौन सा है, सर्किट ऑफ चॉइस फॉर कंट्रोल्ड वेंटिलेशन कौन सा है, ठीक है। वो ज्यादा सर्किट का डायग्राम, पूरा डायग्राम याद करने की जरूरत नहीं है आपको, डायग्राम्स का तो उतना ज्यादा वो नहीं पूछेंगे। सो होप द सेशन वाज हेल्पफुल मेरे भाई, चलो ठीक है, राइट, डन। Okay guys, with this I am turning, okay, I'm switching off this, okay.